think there's a great knowledge. There's a great potential to be tapped there in terms of the integration of AI and not only breast cancer in particular, but I think all cancers in general and how that's going to shape the future of medicine moving forward.
Yeah, you're very right. And that's one of the ways, if you don't integrate AI right now, you'll be left behind. We need to embrace it and be part of the revolution. Ladies and gentlemen, welcome to another episode, special episode of the Cameroon Town Hall. And today we will be talking about breast cancer. And it's always a privilege for me to come over here and for us to have a discussion. I'll call it a discussion. And please, it's going to be not a one-man show. After every session, I will allow the audience to really ask some questions and for us to talk about it. It's actually more of a lecture series, and the goal is for us to educate young physicians, nurses, nurse practitioners, health workers, laboratory technicians, and those who are doing research in healthcare, those who are in the IT field, those who really want to advance the field of breast cancer in Cameroon and in Africa in particular. So a lot of you do not, some of you do not know me, and why am I doing this? So I will, just briefly tell you a bit about myself. And I am Dr. Munoh Kenne Foma, and I'm a medical oncologist and hematologist. I also am an internist. I trained in New York City, and presently I work at Presbyterian Healthcare System, and I work in Albuquerque, New Mexico. I'm also an assistant professor in medicine at Richmond University Medical Center. And back home in Cameroon, I was a trained clinical pathologist before moving to the US, and I do have a master's in public health. So I have a passion for education and really to educate the young generation. And I think this breast cancer series is one of those passions. The question becomes, why did I decide to do this? So the model we're going to have today we'll talk more about, I was planning on talking about two models, but I realized it's going to be very intense for those who are here and will not have time to interact, because interaction is very important as I'm looking at it. So today we'll talk about screening, local management of breast cancer. Why? This is the beginning. This is where the internist and this is where the general practitioners really have a big influence to make, and our nurses and nurse practitioners out there in Africa. For my disclosure, this presentation does not represent the view of Presbyterian Hospital, neither does it represent the view of Richmond University Medical Center. I would start with, I usually love to start my talks with questions. And please, we'll go over those questions. They're just to help us understand this lecture better. So all of the following increase a woman's risk for developing breast cancer, except, this is not a poll, prior biopsy showing atypical ductal hyperplasia, that increases the risk of breast cancer. Late age of first birth, it does increase the risk of breast cancer, as you realize. Alcohol consumption, which is very rampant in Cameroon, does increase the risk of breast cancer. Breast implants do not. So that's very important that you know that. So before even getting to the lecture, there are a few things that we can talk about. Breast conserving therapy is a proven alternative to mastectomy in the treatment of which of the following? So what do we mean by breast conservating therapy? That's what people call lumpectomy, or some people do call it segmentectomy, no matter what, or partial mastectomy. If a patient has multifocal ductal carcinoma in situ, I'm going to explain what that is. Can you do a breast conservating surgery for that patient? The answer is no. Once it's multifocal, no matter how much you take, there's still going to be cancer in situ in there. Localized early stage breast cancer. Yes, you can do that. You can do a breast conservating surgery. But we'll talk about why it's very difficult to get breast conservating surgery in Cameroon. Many people do it, but I don't think it's adequate. Patients with diffuse scleroderma on active treatment. What is scleroderma? Is when you have a disease that actually, a rheumatological disease that affects the skin and the soft tissue. These patients usually need surgery. Why? Because if you do a breast conservating surgery, you need to get them into radiation. Patients with positive margins following lumpectomy. Most patients you can re-resect, but these patients may need a mastectomy. Our next question really for the audience, before we get into the talk, all of the following are true with respect to centenary lymph node surgery, except what is a centenary lymph node surgery in the first place? In breast cancer surgery, you will learn today that we used to do a lot of axillary lymph node dissection, meaning under your armpit, we used to take all the lymph nodes out. We realized that we're causing a lot of harm to women. So the centenary lymph node is the lymph node which is closest to the tumor. So we have here, tracers can be injected in the supraareolar or the peritumoral location. That is right. I'll show you guys how that is done. This is not associated with risk of lymphedema. That is wrong. It is associated with risk of lymphedema. There is upstaging of patients through detailed pathological assessment. That's true. Selected patients with a positive centenary lymph node can avoid completion of axillary lymph node dissection. Yes, that's true. The other question before starting this session is a 45-year-old premenopausal woman. What you realize at the end of this talk is that we treat women who are in menopause different from women who are postmenopausal and women who are premenopausal. The treatment of breast cancer and breast lesions really vary depending on your menopausal status. So a 45-year-old premenopausal woman has recently had a breast reduction surgery with incidental finding of lobular carcinoma in situ. So I'll tell you guys, I'll start by defining terms to those who don't know exactly what these terms mean. You could recommend which of the following. She's premenopausal. I'll show you guys today that all the medications that are used for prevention that were done in postmenopausal women except for tamoxifen. So she cannot get exemestane, which is an aromatase inhibitor. Raloxifene is not a good medication for her because she is premenopausal. Unilateral mastectomy to remove the LCIS. We do not do surgeries for LCIS. That's a take-home message too. Tamoxifen, yes. The next thing is this same patient is started on tamoxifen. After 5 years, she is premenopausal and no other breast event has occurred. What should you do? Extend tamoxifen for an additional 5 years. We don't do that for LCIS prevention. We do that for patients who have cancer, which is a different thing they have. That's patients who have infiltrative disease. Switch the anastrozole and complete an additional 5 years. That's not true. Discontinue endocrine therapy. That's what you do for those women if you're doing it for prevention's sake. Our next question is a 57-year-old woman has DCIS with microinvasion. There is no ink on tumor. This is where we have a big problem in Cameroon because pathologists don't report things very well the way they are supposed to. Most pathology reports are not up to standard. Is she considered to have adequate margins? The answer is no. You need at least 2 millimeter margins when you're dealing with patients who have DCIS. So oncology is one of the disciplines. We always say it's the only discipline where when you're dealing with cancer, where people must work together as a group. In Cameroon, we have a tendency of doing things by ourselves. Surgeons just want to do surgery. Nobody refers to the medical oncologist. We need to work, no matter the stage of the cancer, we need to work as a team. So it's a team sport. It's not an individual sport. And it's not a sport where someone is better than the others. Most patients need this team. Like in breast cancer, let's say the earliest stage of breast cancer, you would get at the end of this lecture, you realize that every specialist is involved. The oncologist is involved, the surgeon is involved, the radiation oncologist is involved and needs to be part of this treatment. You have nurse navigators, you have social workers, you have everyone else which is part of this team. There is this book called, those who are interested in oncology, The Emperor of All Maladies. It's a bit old now because things have changed in oncology, and I would love everyone here to buy one, read it, and you get to understand really how much oncology and the cancer diagnosis affects your patients and the history of cancer itself. So before I get to the epidemiology, are there any questions? This is how we're going to talk, okay? All day is going to be a really chat between ourselves and those who are present here. Any questions? Okay, if no questions, let's move on because we have a lot to do. So considering the epidemiology, I would start with a case. The reason I'm starting with this case is because this woman is quite fortunate. And the next case is a late friend of mine who gave me permission to use her case. And she told me to promise her one thing, that I should get into an education in Cameroon about breast cancer. This is why I'm doing this. That's why I told you guys I was going to tell you why I'm doing this in the first place and why I even started this whole series. So this is a friend's mom. She's 60 years old, Cameroonian female with no past medical history, came to the US to visit her daughter. And she had never had a mammogram before. While she was having a shower, she discovered that she had a lump in her breast. She was very lucky. The daughter took her to the hospital. She was visiting in one of the cities in Maryland, and she had a mammogram done. And the mammogram showed a very small lesion. The mass had not gone anywhere. She was actually a stage 1. And they did a biopsy. In the US, everyone gets an ER/PR status in less than 2 days. She knew she was ER/PR positive and she was HER2 negative. By the end, if you don't understand those terminologies, you can ask, I will explain them to you. And what happened? She did see a surgeon. The surgeon sent her to see a medical oncologist. After the biopsy confirmed invasive ductal carcinoma, she underwent a right breast lumpectomy. If you see her breast right now, there is no signs that she even had surgery. She had a centenary lymph node biopsy that was done, which was negative. And they did, post-surgery, they did something called an oncotype. An oncotype is done to see if you need chemotherapy or not. Her score was 6, meaning that she did not need chemotherapy. And this lady actually is presently on hormonal therapy. She's doing quite fine. She returned to Cameroon and comes here to visit. How common is this situation in Cameroon and Cameroonians who are in the diaspora? Very common. How common do we not do screening? And I would show you there is no screening guidelines for breast cancer in Cameroon. It's not part of our paquet minimum, that's how it's called, minimum package of activities in order to screen for breast cancer. But right now, things are improving, and you do have a mammogram in all the 10 regions. From what I know that was being installed, the question is it appropriately used? Are young clinicians trained to understand how to use it? So this is the good case scenario. This is my lovely friend. So at the time, she was 32 years old. So she's a 32 years old Cameroonian female with no past medical history. She was diagnosed with a lump in her breast, which I did not know about, in Douala, where she was working at the time. And no one did an ER/PR and HER2 status. She was working in a company. She was making more than 1 million CFA in Cameroon at the time. So she could afford anything, and her family is quite wealthy. The patient got a right breast lumpectomy that was done in Douala with pathology indicating invasive ductal carcinoma. Centenary lymph nodes were not done. At the time, I don't know why. If you look at the size of the tumor that was taken out, it was actually a stage 3 already. So post-surgery, no ER, no PR, and no HER2 status was done. The doctor was unaware of anything called an oncotype, which could be sent if they wanted to, and Central Pasteur could send that to France. If that was sent, her pathology could also have been sent to Central Pasteur to get an ER, PR status, which was not done. So no metastatic workup was done at the time for her, which is not correct. She did not get any adjuvant therapy. 6 months after surgery, she developed a local reoccurrence at the breast that she had a lumpectomy. And you do not do a lumpectomy without doing radiation. She did not get radiation at the time because of lack of knowledge from the surgeons that she needed radiation. And also, at the time, no radiation machine was working. That was before the complex Abikoko came up. So this time around, they did a mastectomy and still did not send out an ER and PR status was not done on her. She did not also even get a staging workup. There was no CT chest, abdomen, and pelvis that was done for this lovely lady. Now, few months, just about 2 months after the surgery, she started having bone pain, which is very common. And she had bone pain. And then I still did not know she had breast cancer and called one of her friends who was a young doctor here, and they told her to do a CT chest, abdomen, and pelvis. It showed, sadly, metastatic disease in all the bones and also visceral disease in the liver. She was started on chemotherapy still without knowing the ER, PR status. I was called in 2021 by the mom, and at the time, she was very sick. She was cachectic. She was in L'Hôpital General, and we asked for her to get an ER, PR status done. It was sent through Central Pasteur. It took about 1 month. Once we got the result, she was ER positive. She was HER2 negative and PR positive, and she died 2 days after, 2 days before I got the result. Why is this case very important? That's the most important thing you want to know. Why is this case such an important case for us all? It's because it reflects how all these doctors could be sued. To be candid, this is poor treatment. This is inadequate treatment. This is lack of knowledge. And that is why we're doing this. During the time when I saw her, she promised me that we should be able to, if her doctors knew that. Why? Because she was ER, PR positive, and we do have tamoxifen back home. We have anastrozole, even the minimum things. They would have worked better in her situation than mostly the chemotherapy that she got. Did she need chemotherapy in the first place? That's questionable, and the answer may be no. And would she have been treated better if we had done lymph node biopsies? Yes. And if we had done ER, PR status, what we call immunohistochemistry, yes. Even now in Cameroon, as I'm talking, in-house, there is no place in Cameroon that does in-house immunohistochemistry staining, and it's still not acceptable. Central Pasteur sends it to Senegal and to France. Nobody does it in-house. Then you do have Bingo sends it to the US. There are others who do send it abroad, but it's something that should be part of the testing and investment in these women. All oncologists, there is no way you should advocate for your patients if you're here and you're going to be treating breast cancer. No oncologist should give someone chemotherapy, which they're going to spend millions of dollars. Bingo does this at about 80,000 francs. They should get this done first. If they don't have this, there is no way you can treat breast cancer. This is a call for advocacy. For anyone who is sitting here and listening to me, it's actually a call for advocacy. You should be your patient's advocate. Even if that's the last money they have, test them for the ER, PR status. Don't send them for chemotherapy, test them for the ER, PR. Chemotherapy in Cameroon is not cheap. You're not doing them a favor. They may never even need chemotherapy in the first place. That's what I tell a lot of my patients who come to my office. I have 80-year-olds who come in. I see about 10 breast cancer patients a day. I have 80-year-olds who come in, they give me an ultimatum from the door. I do not want chemotherapy. My next question is that you may not even need it. So let's get to that. You may not need it. So that's very important when we talk about this topic. So for now, the first thing I want you all who are here is to understand the terminologies that I'm going to use. This is the structure of the breast. Every tissue here can have a cancer and it's going to have a different name, depending on what cancer it is, what tissue we do have. Your breast is made up of fat, it's made up of blood vessels, it's made up of this guy here. These are the ducts, these are the lobules. That's where breast milk is produced and they run through the ducts. In breast cancer, these are the most common parts that we talk about when we talk about breast cancer. Either they're in the ducts or they are in the lobules. You could have fat tissue could develop cancer. It's very rare. These are lipomas, liposarcomas. The bones can develop sarcomas. The muscles can develop myoliposarcomas. Everything here, the vessels can develop angiosarcomas. You can have multiple kinds of cancers. But the most 99% of breast cancers develop in the ducts and in the lobules. So if you have a duct here, this is a duct, this is a cross-sectional section of a duct. Once you have cancer cells inside the duct, which has not burst through the trauma, this is called ductal carcinoma in situ. That's what we call stage 0 breast cancer. Once this gets out of the ducts, this is when we start calling it breast cancer. This is invasive ductal carcinoma. Now we can stage it. This is really where this comes. And it's important to understand these terminologies because today I'll be talking a lot about this. The next thing is when you talk about lobules. In the lobules also, you could have cancer. When there's cancer cells there, which have not passed through the stroma, we have lobular carcinoma in situ. In situ means they are still inside the stroma. And that is not considered to be cancer. Once they get out, it becomes lobular carcinoma, invasive lobular carcinoma. So that is the definition of the terms we're going to use. Are there other types of breast cancer? Yeah. Many other types, as I told you, every tissue can form cancer. And depending on the origin, if it's coming from an endothelial lining, it's called an adenoma. If it's coming from a muscle, a skeletal, or any of those are sarcomas. And this is the terminology. If it's coming from the epithelia, it's squamous. So those are the way cancers are actually classified. Now, why breast cancer? Breast cancer is the most common cancer in women. It's the most common cancer in Cameroon. You cannot avoid it. If it's coming out and you have fungating mass, you know about it. A lot of other cancers like colon, they are not being diagnosed frequently in Cameroon because they are found in the colon. If we don't have the technology to do colonoscopies, we will not know about them. Here is the data in Cameroon. And the limited data that we have, because we don't really have community data. These are based on the patients in the hospital. So breast cancer is still number one, 21% or 20.1% of women do have it, followed by cervical cancer, which we'll talk about some other time during the town hall. Here are some referral centers in Cameroon. If you have a patient who has breast cancer, the Baptist Mission is doing a wonderful job in Cameroon. I must acknowledge that. They are bigger hospitals, but the Baptists tend to be comprehensive in the way they treat cancer in Cameroon. Very comprehensive. They do things by the book, and they actually have system in place where even L'Hôpital Général does not have. We have individual talents in L'Hôpital Général, L'Hôpital Central, HGOP, but there is no system in place designed for really treating these patients. Chantal Biya Foundation for Childhood Cancer has a good system in place. As I told you guys in my background, I know Cameroon very well. I studied there and I was a clinical pathologist. So I know Cameroon very well before even moving to the US. So it's a place that I have communication with everybody. In places like La Quintini, which should be a big referral center, they are not even capable of doing immunohistochemistry standings. They do have a good individual talents, but as a group, functioning as a group in order to take care of cancer care, no. Gyneco-obstetrics in Yaoundé, Professor Mbo is trying to get a cancer unit, which I hope is going to get done. I'm in communication with Professor Mbo all the time. We hope this helps in treatment going forward, especially gynecological cancers. And the breast is a breast in the US and in all other countries, the breast does not belong to gynecologists. I'm sorry, the breast belongs to surgeons. The breast is not a gynecological organ. So I'm sorry for all those who are here. The breast is not a gynecological organ, it's a surgical organ. And breast surgery should be done by surgeons who are trained in breast oncology. Now that's going to be another topic. We do know that breast cancer is the most common cancer in women worldwide and also in Cameroon. And this is a very important slide. Why is it important? Without knowing the hormonal status, as I said, you cannot provide patients the best care. Why? Because you would understand worldwide, 70% of all, 70% of all breast cancers are hormone positive, ER, PR positive, HER2 negative, meaning that majority of them do not need chemotherapy. Why did I present the percentage? Because the mortality and morbidity of these cancers depend on what type of cancer they are, given their hormonal status, the IHC. The immunohistochemistry staining determines what and how these patients will survive. If they ask you, with triple negative having the worst survivor. And in the US, we have realized that Blacks tend to have more triple negative breast cancer than every other group. And that is the same for Africa. If you do the statistics in Cameroon, you realize that triple negative may be higher than the reported percentage that you have worldwide. Why? Because Blacks tend to have a higher level of triple negative breast cancer. This has been proven statistically over and over again. But still, hormone positive breast cancer, which is HER2 negative, is still the most common type of breast cancer. It's still going to account for more than 60% of all breast cancers that you would have. So it's important. No one should tell you, even if for NACO's sake, those who do NACO in Cameroon, those who are here who understand the terminology, no one should tell you, let me just go ahead and give them chemotherapy. They are poor, they cannot afford. If they cannot afford immunohistochemistry staining, they cannot afford chemotherapy. Because they may not even need it. Even if they have metastatic disease, they may need just hormone, they may need tamoxifen, and it's going to make them, they will live longer than you trying to give them chemo. People need to understand this. What is the biggest risk factor for breast cancer? It's age. It's being a woman first, and then age. As we age, as women age, it increases the likelihood of them having breast cancer. It's not the genetics. The genetics is going to be the biggest impactor, but not the biggest risk factor. This is a known modifier risk factor. So all women need to be tested. They need to be having the mammograms, which we'll talk about. If you live up to the age of 80, 1 out of every 8 women is going to have breast cancer. For men, men can have breast cancer, but it's a rare event. If a man has breast cancer, you should do genetic testing, which may not be available in Cameroon, but can be a sent-out test. If you are a man and you have breast cancer, your family should be tested for the BRCA2 gene, BRCA1, and other genes that we'll look at. So you can see here that with age, the likelihood of developing breast cancer increases, colon cancer increases, all cancers, most cancers, let me not put all, but most cancers do increase as we age. And that is why breast cancer is very important. So it's super important that we do that. And it's very important that we get a lot of these things tested. Yeah. Someone sent me a message telling me that there's COC in Bakoko. That is true. COC is there in Bakoko, and they are doing a wonderful job. They had presented in the town hall. We'll talk about that. The next thing is looking at other risk factors. You have to differentiate modifiable from non-modifiable risk factors. Old age. You cannot change your age. Women are going to get old, so we need a screening protocol in place. Most African women do have dense breasts, which also increases their risk for breast cancer. Having breast cancer before, if you've had breast cancer before, your risk of having it again increases. Parents and siblings with breast cancer, even if your genetic test is negative, because we have genes of unknown variant, we don't really know what they are. Maybe with AI technology, we'll start identifying some of those genes. We have mutations like BRCA1 and BRCA2, just to name a few. Things like in Africa, we have not studied all the groups, so we know Ashkenazi Jews do have a high risk for breast cancer, but in Africa, we are still to study. We have very limited study. Alcohol use, overweight is one of those things. So if you look at the risk factors, the relative risk, those who have a BRCA1 and BRCA2 gene have a relative risk of breast cancer of 10. That is by far higher than any other thing that you find here. Things like early menarche, late age of first child, we'll talk about that. Benign breast lesions that you've had before, like LCIS, DCIS, they do increase your risk for breast cancer. Hormone replacement therapy, alcohol consumption, obesity, family history, these are all other things. So BRCA mutation accounts for 10 to 20% of all familial breast cancers and 5 to 10% of all breast cancers. There are other genes that you'll be very surprised. Before ever doing oncology, I was of the opinion, oh, maybe Africans do not. Few of the Cameroonians who have moved here, Nigerians that I have treated or have discussed their treatment, I was very shocked to see the level of BRCA positivity. I do have a Cameroonian friend who has Lee-Framini syndrome, and she just did not know why people were dying early in her family. A lot of them had cancers and nobody actually had diagnosed. There is Cowdy syndrome, there is Puch-Jaeger syndrome, there is CDH syndrome, CDH1. I have a Cameroonian friend who has CDH1, and the brother had gastric cancer, and there is high risk for breast cancer. There's PAB2. These are all mutations. If you don't test, you will not know. So factors that reduce breast cancer that you can tell women, breastfeeding has been shown. The relative reduction risk is very low, but breastfeeding does. Age 20 of first pregnancy, if you had your first pregnancy less than 20 years old, usually you have an increased reduction. Women who have had oophorectomy and women who exercise. Here are other lesions that you find in the breast. This will be found mostly by gynecologists, depending on what country you are, or breast surgeons, where you would have cysts do not increase the risk of breast cancer. Fibroadenomas do not. Ductal ectasias do not. And mastitis do not, those who have had infections. But things that do, the greatest ones are lobular carcinoma in situ and ductal carcinoma in situ. So all women without contraindication should be recommended endocrine treatment if they are at high risk. This is now for prevention. If you see a woman who has a high-risk lesion which is not breast cancer, let's say LCIS, women with a high family history of breast cancer, women with BRCA genes positive, they should be given preventive treatment for breast cancer. How is that done? We usually have high-risk women are assessed, those who have had LCIS, strong family history. There is a model you can get online. It's called the risk model, such as the Klaus model. There's the Tyler-Croson model. These have existed since 1980. If you don't know about these, are old things. There is the Gale criteria model that was developed by the British. And these are all things you can just put the patient's information. You will know their risk factor. These women need to be given prophylaxis to prevent breast cancer. But you should understand how to give those drugs so that you don't do harm to them. This was not something that we're just talking about. Everything I'm going to present to you today is based on clinical trials. So this is the NSABP trial that led to us giving women prophylactic treatment in order to prevent cancers. This is for prevention. What is NSABP? This is, you find, they did a lot of the majority of trials. This is a group that was created by the NIH. It's called the National Surgical Adjuvant Breast and Bowel Project. They carried out more than 1,000 trials up to now, and they have really shaped the field of oncology. Women were randomized with high risk to get tamoxifen compared with placebo. And what we found out was that by giving them tamoxifen, we reduced the risk of them getting breast cancer in the future. And so as a GP, you should be able to screen women at the age of 30 to know what their risk factors are when they come into you. This is what GPs should be doing. General practitioners, their job should be the gateway of preventing disease, not treating disease. They should be the preventers of disease, and that's how we should train our young physicians going forward. There was another trial, which I'm not going to go into the details, called the STAR trial. This compared, because, so some of you here who, have any of you really gotten to prescribe tamoxifen? Is there anyone here who prescribes tamoxifen? You will know that tamoxifen has a bad PR. That's the PR for tamoxifen is that it can cause uterine cancer, which is true, but very rare event, and it can cause blood clots. So our goal in the STAR trial was, should we replace it with roloxifene? And when they did a clinical trial comparing tamoxifen and roloxifene, we found out that in postmenopausal women, roloxifene is as good as tamoxifen. Less better, but actually still prevents you from having breast cancer in women who are at risk. And we found out that these two medications work very well, but roloxifene does not increase your risk for uterine cancer, nor does it increase your risk for having clots. So there have been other studies for prevention. Now we're talking about prevention. We're not yet talking about a woman who has breast cancer. Medications like exemestane, anastrozole, lestrozole, and have all been shown in postmenopausal women to reduce the risk of breast cancer in high-risk women. So this is a summary of all the trials that we have done so far in the preventive method, meaning that you come in to see me, you don't have breast cancer, but you do have lobular carcinoma in situ, or you do have a high risk, 10 of your family members have had breast cancer, then you have dense breasts, and I think that you're going to have cancer in the future. By giving you these medications, I can prevent you from having cancer. This is a means of prevention that primary care doctors should know. Do not abuse it if you don't know how it works. You should be able to educate yourself and get more information in order for you to understand it. So the question about if these risk models have been validated in our population, that was a question that was sent in the group. And the answer is always no, because we have to invest in research. There is so many research questions for us to give our students. Some of the models have been partially validated, like the Tyler Crescent model, but full randomized trials have not been done. And they have done subgroup analysis also that with Blacks that were involved. And that is why the CDC, the NIH, everyone is now invested in making sure that Black populations are represented in all clinical trials, because we are different. And we don't know exactly how these trials will be once done in Africans and Blacks. So it's very important that we know these things and we get this. So there is a summary by the end of after this, I'm going to leave things open a little bit. There is always a summary by the end of every presentation I do in order for you to take home message. So what's the take home message for prevention? Prevention is always better than cure. We should identify women who are at risk, women who have LCIS, atypical hyperplasias that you see. You should also identify women by using the Gill model, by using the Tyler-Crescent model, in order to identify these women who have not yet had cancer and be able to provide them with prevention. What are the drugs that we can use for prevention? For premenopausal, those who are young women who have not yet reached menopause, the only medication for prevention that can be used is tamoxifen. It's available, it's cheap, it's generic. Postmenopausal women can get tamoxifen, roloxifene, exemestane, and anastrozole. And we can also use a baby dose of tamoxifen. Lifestyle modification should be advised to these women, exercising. And there is a type of exercise when if you exercise at least 150 minutes of moderate exercise or 75 minutes of high intensity exercise, at least 3 times a week should be good enough. Limit alcohol drink, especially all those we are Cameroonian, so we love alcohol. This will reduce your risk for breast cancer. Here is, in terms of prevention, I'm just summarizing risk factors. You can see here, there are non-modifiable risk factors. You guys cannot change this, but you should work on things you can change. You can't change your gender as a woman. Your likelihood of getting breast cancer if you live to the age of 80 is 1 out of every 8 women. As you age, your risk for breast cancer increases. That's why we stopped. We no longer tell women after 75, oh, we're not going to do mammograms. It depends on your performance status. If your performance status is good, we'll continue mammograms till. Now, genetic factors, you don't change your genes. Early menarche is also part of genetics. You don't decide when you start having your periods. Family history, important. You cannot change your family. Late menopause, you cannot change that. Exposure to radiation, you can change that, but some patients get radiation because they had cancer. So like lymphomas, Hodgkin's, and all of that. Now, things that you can modify. Having no child can increase your risk. Giving birth at a late age can increase your risk. Not breastfeeding your child can increase your risk. Using hormonal replacement therapy can increase your risk. Using hormonal birth controls can increase your risk. Eating a lot of processed food has been shown to increase your risk. Either it's an indirect or direct factor, lack of exercise and obesity. So far, we are going to move to section 2. And there is a very important question here that someone asked Dr. Njebazi, is there prevention treatment for breast cancer in men with high risk? Yeah. So in men with high risk, yes, and you need to document that they are BRCA2 positive, you can give them tamoxifen. Very controversial, but that's the only drug that has been studied in men. And all men can get it. No other drug, but tamoxifen can be used. Now I'm going to pause for a few minutes, and please, you can unmute yourself if you have questions before we move over to the second part, which is going to be about screening. We're going to talk about screening in the second part of our lecture. And as a PCP in the US, can I also get genetic testing approved? Oh yeah, so at the moment, approving genetic testing can be very tricky. The reason it can be tricky is because every woman who has breast cancer now can get genetic testing. We no longer use the criteria. It's now approved. Every woman who has had breast cancer can get genetic testing. And there is reflex testing in their family members if it's positive. But in order to get genetic testing for someone who does not have breast cancer, what you need to do is prove that they are at high risk for breast cancer. And now approval insurance companies are different. They are not the same. I've always had, even us oncologists, we fight with them, depending if you're dealing with Humana, if you're dealing with Presbyterian, if you're dealing with Pfizer, each of them are completely different. And some push more than others, but you can get this test approved for patients. So now we have 5 minutes. You can unmute yourself. If you have questions, you can always unmute yourself and ask them. It's a discussion.
Yeah, thank you, Dr. Munoh, and greetings to everyone. And thank you, the town hall, again once more. This is Franklin Maloba speaking from the US. Yeah, Dr. Munoh, thank you for all the sacrifice you are doing to our population, especially to the women and maybe some men. Yeah, a quick question is that, back in Cameroon, a lot of women live in the royal area and they live on firewood. They depend on firewood as a source of cooking. And I have learned that this smoke from firewood is also a risk factor. So what then can you tell those women or advise them, because this is their lifetime and they have been living for this for many years? What can you tell them to do with the present situation? And what should they do to know if they are cancerous and what become of that? Thank you.
Yeah, thank you, Maloba. That is a modifiable risk factor for lung cancer. And modifiable risk cancer for all cancers that smoking causes. That's a strange thing. You realize that once you're studying the African population, women tend to have more lung cancer than men because of the socioeconomic conditions and those who cook food using firewood kitchen. That's something that has been documented. For breast cancer, we don't yet have research showing that smoking actually increases the risk for breast cancer, but it increases the risk for 27 other cancers. From the mouth right up to the anus. You start from tongue cancer, throat cancer, or head and neck cancer, lung cancer, bladder cancer. You can call 25 of them. How do we mitigate this? Is by getting people, engineers, to invest on ways of modifying the firewood kitchen, lifting our patients, our people out of poverty, doing screening, not only for breast cancer, also for lung cancer in these women who have been cooking for 60 years. In the US, we say those who have smoked 30 pack years, but there are women who have been in the firewood kitchen for 30 pack years. And that is equivalent. It's the soot that actually increases the risk of the cancer, not the nicotine. So these women are at much of a risk for developing lung cancer and other cigarette-inducing cancers as those who smoke. So it's going to change the whole fabric, but there is a lot of research. I'm not an engineer, going into how to modify the firewood kitchen and make sure that the soot is sent out in a chimney. Those who are there do not really get the soot and all of that, like how it's done. Those who do heating of their houses here in the US and other things. So there is a lot of technology going into that. And I would want, without research, we cannot even know the percentage of those who are using firewood and developing lung cancer and other cancers. But I think that's a field where we need a lot of research. Anyone else?
I have a question.
Yes, please.
Thank you so much for your very informative presentation. I just want to clarify on the risk factor that you presented. Something like anastrozole. I've seen it used on my patient population specifically because I have a younger population and older too, for PCOS and ovulation induction, specifically for fertility. Would that increase the risk of breast cancer as well?
No, anastrozole
Okay.
actually decreases the risk of breast cancer. It's an aromatase inhibitor. It blocks estrogen, specific types of estrogen that is designed for the breast. So using it for women in fertility, in those who are infertile, we're using it for another, we're using it in order to help for ovulation. That's really the goal behind it, and preserve the ovaries, but it does not increase risk for breast cancer. Now,
Thank you.
women who are on hormonal treatment, that's adding estrogen and progesterone, it's a big debate how much they do increase. If topical versus IV, that's a debate we can get, but generally there's a consensus that it does increase the risk for breast cancer.
So you don't, just to expand on that, as far as the HRT, the hormonal replacement therapy, so the theory of that, the research that was done years ago was skewed, is not totally right? Because I hear that back then it was not totally true, the research that was done. That's why hormonal replacement therapy is pushed now to prevent all the menopausal symptoms and things like that.
Yeah,
I mean, I'm speaking specifically in the US.
There is mixed data, meaning that there is mixed data in this field, but there is an overall consensus. There is enough evidence to show us that estrogen-containing hormone replacement therapies can increase the risk of breast cancer. Okay. But the controversy is just about how the research was done, but multiple other research have been done in Japan, in Asia, backing up this. And that is why till now, if you have had breast cancer, we give women who have never had breast cancer with a low risk of getting breast cancer. The Gale score is low, the thyroxine score is low. We can put them on prevention medications without being bothered. But if you have already had breast cancer, we are all very cautious deciding to give you oral estrogen-containing medication.
Birth control.
Yes, birth control. We try not to. Some women, it's really bad. I've had women who have attacked me. They're already having breast cancer. They're on anastrozole. We have ended up giving them the creams. But still, if you go to the NCCN guidelines and you look at the ASCO guidelines and you look at the ESMO guidelines, they all are against it.
Okay.
Good. Any questions?
Thank you.
Yes, one last question. You mentioned something like women born from maybe mother that were having breast cancer. At what age will you advise them to start screening for breast cancer? And finally, this question may sound a bit funny. What about transgender men who are living on this hormonal therapy? What becomes of their risks in terms of exposure to breast cancer? Thank you.
Excellent question. Now, age. If you have a family member who have had breast cancer younger than age of 40, you should start screening 10 years before that person. That's 10 years, 5 to 10 years. So your screening, if someone had it at 40, you should start at 30 or 35. That's how the recommendations are, depending on the country where you are. Now, for transgender men who have been on hormonal therapy, that has not been studied, but there is empiric data showing that their risk for breast cancer increases also by being on long-term estrogen and progesterone. Okay, let's move over to our second part. As I said, it's going to be a discussion. I know it's going to be long, but the second part is going to be screening. Why is screening important? Screening is the only way right now in Africa where we can get breast cancer early, treat them early, and actually provide a reasonable survivor. In the US, survival of breast cancer patients is 98%. There are countries where it's better, Australia and New Zealand, better because everyone gets screened. Here, there are still some populations that are discriminated upon, though people don't want to accept. There are population, Hispanics, Black Americans that do not have access. Those are all determinants of health. Now in Cameroon, this is from WHO, and I know what happens in Cameroon. Do we have a policy for breast cancer screening? The answer is no, we do not. This is the most recent policy. We don't have a policy for breast cancer screening. Just by having a policy in place for breast cancer screening, we can do a lot. Now, all the 10 regions, if I'm not mistaken, do have a mammogram. The Minister of Public Health was installing the mammograms recently, and it should not just be a machine that is sitting there. GPs should be trained to understand who is going to need screening and who not. That is a big debate that we'll talk about right now. What is the place? What are the methods that you can help screen women? You can educate women to do self-breast exams. In the US and in Europe, it's not advisable because it deters women from getting mammograms. But there is something else we call breast awareness, which I promote. Know your breast. Nobody can know your breast more than you. Even your gynecologist will not know your breast more than you. If anything changes in your breast, that's it. Anything changes in your breast, inform your primary care or inform your gynecologist or inform the person who is seeing you. Clinical breast examination should be done in Cameroon for women who are above 40 years. In Europe and in the US, it's still not advisable because you need to get them to do a mammogram yearly. It's not, we don't want you to be doing clinical exams and telling women not to get mammograms. Your hand and your clinical exams will not identify DCIS at all. So don't feel that you're a magician, but in Cameroon, in Africa, where we don't have access to these things, we should get women, we should do breast exams at least once a year in the office. Mammograms. Who gets a mammogram? In the US, right now, there is a consensus. There was no consensus before this year. We now accept everyone 40 years and above should get a mammogram. It should be done once a year. That is the consensus right now. In WHO and in the UK, because of the NIH system, they adopted that we get breast cancer screening from the age of 50 and every 2 years. And I think Cameroon should adopt that. Breast cancer is cheaper, it makes more sense, and it's more cost effective if you're a poor country. Ultrasound of the breast should be done if you have a positive mammogram for everyone age 40 and above. The radiologist will tell you, while people who are age less than 40 should get an ultrasound first and a mammogram next if they have a positive result. Magnetic resonance imaging, I will not talk much about it today, but I have it in my slides for those who are interested. We do it for specific women. The reason I'm not going to talk much is that we have none available in Cameroon. We have an MRI machine, but the adapters to do breast MRIs are not available. So self-exams, you guys all know this. You can go to YouTube and learn how to do breast self-exams, but it's important, especially in the African setting. But I always tell my patients here in the US, I call it breast awareness. No one knows your breast more than you. Mammograms, this is how a mammographic machine is. Some women don't like it because it's painful. If you've never done one and you're a man, you may just want to get women do it all the time. Some women avoid doing it. You should be able to counsel them and make sure that they get their mammograms yearly. These are the US updated guidelines. What does it say? And there are a lot of things here that we can learn back in Africa. All women should have a risk assessment at the age of 30. So if you're back home in Cameroon, you see a 30-year-old, please ask them, is there anyone in your family who has ever had breast cancer or any other kind of cancer? Are you having any of this? Blood discharge? Are you having any changes in your nipples? Do you have a nipple evasion and all of that? These things are assessment that you do. In the US, from the age of 40, we do mammograms yearly to everyone. And now the guidelines say we don't stop at 75 as it used to say. We continue because I've shown you the risk of breast cancer actually increases with age. If the woman is 75-year-old and has congestive heart failure, end-stage renal disease, please stop doing a mammogram. She's not going to die of breast cancer. She'll die of her end-stage renal disease. If the woman is fine, coming to your office like most of my patients, doing fine, I identify almost 50% of my breast cancers are above the age of 75. And they get good surgical care and they get good hormonal treatment and they're fine. Even the higher their age, the less the side effects from aromatase inhibitors. So these are the different recommendations that I've already talked about. Breast clinical and self-exams are not recommended in the US, but they are recommended in Cameroon and other African countries because we don't have alternatives. And that is, in the US, the reason they are not recommended by the American Society of Oncologists is just because we don't want to defer women from not doing mammograms. But you can always take charge of your breast, examine it, and make sure that you do not have breast cancer. If you have a lump, see your primary care. So most WHO recommends biannually, meaning every 2 years, which is something I do recommend as Cameroon strategy. If we're going to put in a policy paper. Now that we have mammograms in all the 10 regions, we should be able to train radiologists. The most difficult part of a mammogram is learning how to read it. It's even in the US, those who read mammograms are actually breast radiologists. They do 5 years of radiology, and they do additional 2 years of breast radiology. So we should be able to train our radiologists to read those mammograms and send them out for sub-specialization, either in France or somewhere, so that they will come back and teach the young generation how to read the mammograms effectively. By putting machines without having radiologists that can read it properly, you are going to do no good to anyone. So that is what my advocacy should be. Cameroon, if we want to develop a policy that is going to be cost effective, is women aged 50 to 75 should have mammograms every 2 years. Those who are wealthy can start at the age of 40 and have it every year. But at least the government should have a policy in place to cover every woman to be able to get this done. So MRIs can be done in spatial groups. They are more sensitive, but they are less specific. I'm not going to pay a lot of attention to this just because we don't even have it back home. But women who are BRCA positive, those who have a first-degree relative, which is BRCA positive, we do have studies that have shown that it does reduce it does reduce risk of reoccurrence. We also do have studies for those who have Li-Fraumeni syndrome, those who have had radiation for Hodgkin's, non-Hodgkin's, and other diseases, those who have Cowdy disease. So these are all things that we do know. Here are some other genetic risk factors that we test, we identify. These people, per NCCN guidelines, also includes these groups of people should be tested with MRIs. And usually what I do with my patients is I alternate them to get MRIs every year and mammograms every year, but they're all 6 weeks apart, 6 months apart. So she gets an MRI now and another and a mammogram in 6 months. So that alternates, and we're able to pick up lesions early and treat them well. So here is just a summary of what I just said. In high-risk populations, start at age 30. And Dr. Maloba, this is the recommendation from this study, 10 years earlier than the earliest age of the member in the family who had breast cancer, okay? General population in the US, we start at 40, but this is heavily debated by the UK and other European countries that think that we are wasting a lot of money. Interval, randomized studies have shown that it's controversial, but MRI is also controversial and depends on whom you want to do, and we don't even have this available, so that's not something I should be fighting and talking about. Our next discussion will be diagnosis and staging. I'll do diagnosis and staging before we get a little break and answer questions. This is a big controversial part because I have physicians who are here. Please, for breasts, you can do an FNA. Don't do an FNA for anyone who has breast cancer. FNA is a fine needle aspiration. Please do not do that. All breast patients should get a core biopsy. You should do a punch biopsy if they have cold orange or they have skin involvement, or they do have cutaneous cancer disease spreading. Excision biopsy, do not do excision biopsies. And I'll tell you all why. So this is an FNA. The reason why FNAs are not good is a fine needle aspiration. You cannot differentiate a DCIS from an invasive cancer, and the implications are terrible and dramatic for this woman. So please don't do fine needle aspiration. If you have never biopsied a breast, send it to someone who is used to biopsying a breast. It could be an interventional radiologist, a breast radiologist, a gynecologist in Cameroon, someone who does it for a living, or a surgeon. Core needle biopsy is the standard. What is a core needle biopsy, and why is it even the standard? It allows us to do immunohistochemistry staining, IAC staining. You cannot do IAC staining on patients who have done a fine aspiration. And it allows us to differentiate DCIS from invasive cancers. So here is how you get a core biopsy, and this is the recommended test that should be done. Punch biopsies can be done. Those who have the skin, that you have all the skin involvement with rash and all of that, you could do a punch biopsy. Just recently, I had a patient who had a mass in the breast. I was contacted in Cameroon, a patient who had a fungating mass. I looked at it during my time when I was doing medicine biologist in Cameroon. I had seen a lot of patients when we used to do patients with, you said, a Brûlée. To me, it looked like Brûlée's ulcer or something else. And this patient was already started on chemotherapy in a well-renowned institution in Cameroon, in Douala. Finally, the biopsy came back and it was not cancer. Yeah, we need to be very careful when we start treatment without even doing biopsies and getting patients treated. So it's very important that no tissue, those who know me here, my students that I do lectures, even the fellows, no tissue, no issue. No, that's like they call me, that's how they call me in the hospital. No tissue, no issue. No hospital should call me when they don't have a tissue. Except you have renal cell that the radiologist tells you is renal, or hepatocellular carcinoma that the radiologist tells you that he's giving his head for it, okay? The rest, other people, no tissue, no issue. There are about 3 cancers. Testicular cancer, you need to take it out. Those are the 3 cancers that you don't need to biopsy. But there are certain situations you need to biopsy. But I biopsy all my hepatocellulars now, especially those with metastatic disease, because I need a next generation sequencing in the US. And that it makes a difference. So it makes a whole difference. So I need tissue for almost everyone. Yesterday, I was on call last night, and the hospitalist called me. There was a patient who came in with a renal mass, and they were debating. I held a whole long debate. It was in the anterior pole of the kidneys, and they wanted to know what to do. Should we biopsy it? Maybe because I've been singing to them that no tissue, no issue. I told them, no, they need to call the urologist to come take out that mass. That's like, the radiologist was very clear that that was cancer, that was renal cell carcinoma, and he met all the standards. So you should be, but in breast cancer, we need tissue, and we need the right tissue. We need to get immunohistochemistry staining done. We need to be able to have the morphology to test for and differentiate DCIS from invasive cancers, LCIS from invasive lobular cancers. That is why we need at least a core. The reason why we do not need you to get this, an excision biopsy, is because most of the time you will come back for a second surgery. And most of the time you're not doing it under the right condition. And most of the time the margins will be positive. And in Cameroon, I've looked at 80% of the pathologist slides that were sent, or the reports. Nobody tells me about level of margins. And nobody tells me how many centimeters those margins have been from the cancer itself. So that's another area of education that we need the pathologist to always report, to have standardized reports that meet the international criteria, so that the surgeons and the oncologists will be able to give a right input of what to do for those patients. But I don't encourage excision biopsies for breast cancer. Do a good core biopsy. Now, centenary node biopsies, becomes a bit tricky. In order for you to do a centenary node, we do use radioactive substance dials, and we do use a blue dial in order to be able to get the closest lymph node that we can take out during surgery and be able to send it out for testing. If they are negative, there's no need for axillary biopsies. If they're positive, then we need to discuss on what to do. So clinical presentations, how do breast cancers do present? They can present in any way. Non-palpable abnormalities on imaging is the main way we diagnose them in the US by mammograms. In the US, that's the main way we diagnose 90% of breast cancers by mammograms now, even in Europe. Palpable painless mass, you get to find women who have had mammograms even 6 months ago and they have a mass. They are able to identify it and come to you, and then you do a mammogram and it's positive. Some people come to you with an axillary lymph node. I've had like almost 10 patients like that throughout my career. They have an axillary lymph node that is positive. The initial breast is even negative, and you find an axillary lymph node and it's positive for breast cancer. It can happen. Less common, nipple discharges, any kind of skin changes, breast pain, and all of that. I always tell women, a lump in the breast, change in the breast, nipple changes, discharges from the breast, skin changes. But my real criteria is any change in your breast, you should make your general practitioner know about it. And the general practitioner should be educated enough to know what to do with that. If the woman is less than 40 years old and has history of people in the family with breast cancer, we should be careful and be able to get them ultrasounds and then mammograms as followed, depending on recommendations. If they are above 40, get them a mammogram if they have never had one. These changes could be just thickening in the breast. I like to use this analogy because a lot of patients, my patients do have oranges or do have lemon or lime. They like one of them. Any hard area in the breast, any dimple in your breast, any nipple crusting, any redness. Don't think that all redness are mastitis. Any new discharge from the breast, which is not there, especially when it's maroon in shape or red or colored. Any skin sores that doesn't heal. Any lump or bump in the breast, any growing blood vessels in the breast, any sunkenness in the breast, any new shape on your breast, peau d'orange in your breast, which is called orange peeling, is in French usually. Any hard lump in the breast should be investigated. The diagnostic workup, like any other thing in medicine, you need to get a good history and physical exams that I rely on the GPs to do. Diagnostic bilateral mammograms, as I said, my recommendation in Cameroon would be for us to adopt the WHO protocol where we get everyone 50 years and above to do mammograms every other year because it's more cost effective. Ultrasounds as necessary, suspicious exams, but negative mammograms, you should be able to get the radiologist to help you with an ultrasound. They're very good at that. Not any technician who has just been doing ultrasounds, please. Make sure that you send to the right person who knows what they're doing. Biopsy of suspicious lesions, including new palpable lesions. In the US and in Europe, this is done by radiologists. 99% of the time, they are good at it. That's why we should train our radiologists to become breast radiologists. I think the Cameroon government should invest in that and train them on interventional procedures. They should do stereotactic and ultrasound-guided core biopsies for you. They are very precise. They can put a clip there. It helps the surgeon. It should not be something, these are times that the field of radiology is taking over a lot of jobs that surgeons think they could do. So we should use them. They are more precise. They should be better trained. Core biopsy needle, these are all things that we can get from our radiology because they know how to read images, they know the location, and they'll be able to pick out that lesion and help you. So genetic testing and counseling should be done for the right patients. If someone comes to you and tells me my aunt had breast cancer, my mother's sister had breast cancer, my younger sister had breast cancer, it should be an alarm to you. If they can afford it, you can actually send genetic testing maybe through Central Pasteur or through the Bingo Hospital or others and try to see what is going on. As I told you earlier, Bingo does immunohistochemistry testing for 80,000. Do not treat your patients with breast cancer. You guys should learn to collaborate together. Do not treat your patients with breast cancer without knowing the IHC. Don't do that. It's criminal. You would lose 80,000, but you would save millions. Why should you, like the case I present, why should you put a patient on chemotherapy who has metastatic disease to the bones and maybe no visceral disease, who has ER/PR positive breast cancer, and you may have placed them on tamoxifen or aromatase inhibitor cheaper They will live longer than getting chemotherapy with all the side effects. Don't do that. Now, I'm going now back to the pathologist. As a pathologist, you should be able to analyze the tissue. Here we have a lot of problems back home, which we have to together try to solve these problems. How do we invest in the private sector to get RAC done? How do we get all the government sectors to get RAC done in-house? Or get a unique pool where it's cheap and affordable, where the government can actually subsidize us getting estrogen, progesterone levels, and the human epithelial growth factor 2 levels, which is called HER2. They are very important in the implication of how you'll be treated. Tomorrow we'll discuss about this. Tomorrow's section is going to be treatment. How do we treat these patients based on this data that I'm telling you? So every patient that comes to you, this is how I analyze all your pathologies. I'm sorry to those that I don't reply their messages. I receive so many messages. There are days I miss some. From those in Cameroon, I truly am very sorry that I cannot reply to all. And I'm also very busy here. I tend to see about 20 patients a day, busy. And so I cannot reply to everyone. But there are days that I miss some messages on WhatsApp. I look at it once a day. But every pathology that is sent to me, what I look at, what is the histology type? What is the grade? What is the estrogen and the progesterone level? What is the HER2 level? What is the Ki-67 level? Those are the things I want to know. Post-surgery, a lot of people don't get pathology, and I want to know at the margins, where the margins, positive or negative, they are never reported. Those are things I want to know because my treatment depends on all of these things I'm just telling you. Understanding the behavior of every cancer is also important and is based on pathology. If you do a fine needle aspiration, you will not be able to differentiate these two things. You will not be able to differentiate non-invasive versus invasive cancers. Non-invasive are DCIS and LCIS. Invasive cancers are invasive lobular carcinoma and invasive ductal carcinoma. Recurrence of disease and metastatic disease, those are all things that we should think about when we're dealing with patients. What type of cancer does the patient have? Is it a lobular or a ductal? I'll give you there are many things in medicine that are tricks. If someone sends to me, and it's always been people send to me, oh, the patient has lobular carcinoma, ER/PR negative. Even in the US, I call the pathologist, can you repeat me the ER/PR status? Lobular carcinomas, they are 98 or 99% ER positive. If you're in Cameroon and someone tells you that, the pathologist tells you that they have lobular carcinoma, invasive lobular carcinoma, treat them as ER positive, full stop. They are hardly or never ER negative and PR negative. So these are all things that you should know. Less common types, as we talked about, they could be inflammatory breast cancers, which they need chemotherapy, but you should be able to really justify that as inflammatory. Tubular breast cancer, colloid breast cancers, metaplastic breast cancers, these are other subtypes. You could also have sarcomas and other things that occur in the breast. You should be able to tell the grade. Grade 1, grade 2, grade 3. This is not a pathology lecture, so I'm going to not there, but grade 1 simply means the cells look like normal cells. Grade 3 really means that the cells are purely abnormal. And you should be able to tell the staging. Why is staging important? Staging is important because it tells you what to do next. Not every woman with breast cancer needs systemic workup, but every woman who has at least a stage 3 breast cancer needs, stage 3A and above needs a CT chest, abdomen, and pelvis. Here in the US, I tend to do a PET scan, and I do an MRI of the brain, especially if they are HER2 positive. I just had a patient recently, she was even stage 2 in the breast. Very sad case, stage 2 in the breast, came, examined her. I was very worried for many things. And I did an MRI of the brain, she has brain mets. Sad, because she was HER2 positive before starting treatment. It was just a sad case. I've had multiple cases like that. So staging workup, stage 1 patients do not need. But these are important things you should look about. Why do you need? Radiologists are going to be able to do biopsies and help you place a clip that would help you in the bed, that can help you during surgery. Percutaneous biopsies and placement of clip in suspicious lesions are usually done easily by radiologists, and it would help the surgeons, the breast surgeons. Now, if you do a CBC, you need to do a comprehensive blood work for everyone who has breast cancer. Let's say I do a CBC and I find out in the CBC that you're severely anemic. and the anemia does not correspond to what you should be going on, there's something happening in the bone marrow. Could it be metastasis to the bones? Yes. So maybe because in the US, all oncologists and hematologists, we tend to identify this early. Comprehensive metabolic panel should be done. Comprehensive metabolic panel can show me the AST and ALT are elevated, even if you're having stage 1. I need to do a CT of the abdomen and pelvis, or just do an ultrasound of the liver. Make sure that there are no liver mets. If liver enzymes are high, alkaline phosphatase being high can tell you that there is bone mets. So inflammatory breast cancer, always consider taking a picture. Why? Because this is going to help you in the future when you start treating these patients. So this is super important. Now, I usually summarize take-home messages. Clinical stage 1 up to stage 2B, if directed by signs and symptoms, they do not need imaging studies unless you can do a bone scan if they have a high alkaline phosphatase. If you don't have a bone scan, you can do a CT. CT chest, abdomen, and pelvis, if alkaline phosphatase is high, liver enzymes are high, or they have some symptoms, maybe abdominal pain or something. CT chest, if you have pulmonary symptoms and they are short of breath. Everyone who is stage 3 and above should get a CT chest, abdomen, and pelvis before you start anything on them. If you are living in a place where there is no CT chest, abdomen, and pelvis, that should be their last money that they should use so that you don't treat them irrationally. The friend I presented in the beginning, she had a stage 3A disease from the beginning and she got a lumpectomy, wrong treatment. She needed a CT abdomen, chest, and pelvis, and I thought that she had metastatic disease right from the beginning. And if she had ER/PR status, which was finally 90%, she would have just gotten an aromatase. At the time, she would have gotten an aromatase inhibitor and gotten Lupron to block because she was 32, and also place her on palbociclib, which we can get in Cameroon. She had the money to afford it, but she had treatment, but she's just had the bad and not the right treatment. All women who come to you, you should be able to define what menopause is. Definition of menopause should be a woman not having her menses for 12 months. If you're doubting, because the treatment will depend on her menopausal status, you can do estradiol, LDH, and you can do estradiol, you can do follicle-stimulating hormone and luteinizing hormone, and use those 3 to decide if she's menopausal. Right now, I will stop here for a short while, and if there are any questions, we can talk about those questions. I see many people agreed. Okay, so any questions, you can actually unmute yourself. And I have Raisa is here. She's actually a breast oncologist, so she can actually give input. And someone asked, Joshua was asking about the needle and the gauge of the needle. Yeah, we'll talk about that. And in the US, so there's Raisa did reply. Thank you, Raisa, for the reply. And any questions, please? Or any additional information before we move on to the next section? If there are any oncologists on the line, I see Dr. Kuya is here, Francine. She's just listening, but she's the oncologist at Bingo. She's doing a wonderful job for those who don't know. Wonderful, wonderful, excellent job at Bingo. And to me, I don't know, I don't want to come across as being different, but I always feel that Bingo provides the best care in Cameroon after reviewing a lot of cases. Even when Bingo sends patients to Yaoundé, a lot of those patients don't know what to do. So it's like we have a referral system that is broken. But because it's just broken, the other places have individual talents, but they don't have a system in place. So you can unmute yourself if you have something. I just want to give a little break for us to try to answer some of the questions. Someone is asking if we have pathways to influence policy. Yes. Policy in Cameroon can be a very tricky thing. And really, that's something we can talk out of this, but we should be able in the diaspora to provide guidelines. That's the way I look at it now, and propose them. If you have a channel where you can propose them to the minister or someone, you should have something in mind and provide a solution. Don't just complain without providing solution. That's the way I think about Cameroon right now. So in Cameroon right now, I feel that we should not only complain, but we should be complaining with solutions. We should educate the young generation. If we don't give lectures like this, they will not even know what to do. And we should be able to answer questions. Please, you can unmute yourself if you have any questions. I see Joshua's hand is up. Please, it's okay. Unmute yourself.
Thank you very much for the excellent presentation, and good evening or good day to everyone from wherever you're joining. Just a small remark about your presentation on the breast cancer screening strategy. What caught my attention especially was the age that you advocated for, 50 and above. Much of our local data shows that the median age of so many of our patients at the time when they are initiated on treatment are in their late 30s and early 40s. So we have a confidence interval of somewhere between 38 and 45. So what do you really think? And much of the literature also shows that the patients in sub-Saharan Africa are at a peak age that is 10 years lower than you find in Caucasians. So from a public health perspective, where do you think, if we really have to use our local data to do breast cancer screening, which age group do you think might have the highest possible impact, when it comes to screening these patients with breast cancer? That's just the first part of my question. Thank you.
Yeah, so that's a very interesting question coming from, I know Dr. Joshua, Professor Joshua Tambe very well. He's both a radiologist and also a public health specialist. So it's a very important question. We need to, going forward, have real data on our population in Cameroon. I always say there are times there is emotional skewness of data where we turn to concentrate on the younger patients. It's true that we have more younger patients, and that is very true. And I think this is a room where Professor Tambe can actually do research for us. I know there is some data, but let us know the real demographic. We have a younger population, truly. Most of our populations, our life expectancy in Cameroon is less than 75. It's actually 60 something. So putting it at 50 could be very controversial, as you're saying. Now, how do we get to screen? We have a lot of young women in their 30s. Can Cameroon afford to actually put a policy in place where we're going to screen women at the age of 30 or at the age of 40 going forward yearly? That's really the policy part of it. I am not going to be able to answer this question, but I think, Professor Tambe, if nothing was happening and I was the one making this decision and I had no financial constraint, I would screen every woman in Cameroon from the age of 40, and I would do it yearly. Why? Because we even have a younger demographic, and those between the age of 30 to 40, their primary care doctor should have in their offices, at least they do it once a year, a triaging protocol in order to determine those who get ultrasounds from you. You know very well the ultrasound is more sensitive for the younger women, and the mammograms if needed. That's really going to be my policy if I have all the financial resources available, meaning the GP should stay in their office and ask these women, one, do you have any family member with breast cancer? When was the last time? Have you noticed any changes in your breast? Have you had any kind of lesion in the breast or all of that? So especially screening them, and then those who are high risk, and they should be able to have the Klaus and the thyroid score that they can administer in their offices at least once a year, and just screen these women, and then we put them in a better situation where we can get mammograms for those who really need it without getting it for those who do not. But going back to the 50 years and every 2 years, that's WHO recommendation, that's cost effective. That has been shown in the UK, which always has robust data because of the NIH, which their healthcare system is universal, so they collect good data, and the Germans also have shown that screening from the age of 50 and every 2 years is more cost effective. In the US, we have a lot of money and it's private insurance, so we're able to screen from 50 and every year. But in Cameroon, I think 40 and yearly should be appropriate, as you just pointed out, but we should get more data And I think that's research that I would challenge you with your students in Boya. You can actually carry out research and let us know so that when we're coming to Cameroon, we have better data in order to do things that reflect. I do not love parachuting medicine. That's what I call it. Parachuting medicine is the act of doing research in the West and then implementing it in Africa. Now, I would see Raisa's hand is up. Please, Raisa, you can help me answer some of those questions. You can unmute yourself, please.
Hi, everyone. My name is Raisa Kedsa. Can you hear me?
Yes, we can hear you perfectly. So,
Okay,
Raisa,
awesome.
For those who don't know, I know Raisa. I'll just introduce you a little bit. Raisa is doing her final year in medical hematology and oncology at the NIH, and she also studied in Cameroon, and her concentration is actually breast cancer.
Yes, thank you so much, Dr. Munoh, Kenne. I mean, you really all said what I was gonna say, and you said it so brilliantly that I was like, maybe I should just lower my hand. But really, we're in an era of where we're doing, risk stratified cancer screening, and so just like Dr. Munoh Kenne said, we use family history, we use genetic factors to sort of tailor the cancer screening strategies. So a country like sub-Saharan, most countries in sub-Saharan Africa are very resource limited, but also you also question whether the mammogram technology is updated enough to be able to capture all the breast lesions. So it's a very complex situation in Cameroon. And what I would say is, I think it's fine to have a cost-sensitive approach with the WHO for the general population, but I think the physicians need to have a more tailored approach, based on the clinical risk, the family risk factor, the family history, the personal past medical history of the patient, and their ability to pay for services. There's no point in recommending a mammogram every year if the patient cannot even feed themselves, right? Like it doesn't make sense. So it's a very complex situation, but the general answer is, I would say, if you're a general practitioner, I would look for modifiable or non-modifiable risk factors for breast cancer and sort of adjust your recommendation based on that. But if ultimately, if the patient is not able to pay for mammograms, I mean, they can always do have the breast awareness that Dr. Munoh Kenne talked about and examine the breast. You'll wonder, you'll be surprised by how many patients would say, oh, I found a lump in my breast, just because they have that habit of checking the breast. But for those who have risk factors and who are able to pay for the services, I think it would make perfect sense to start screening at the age of 40 and even younger if they had a family history of cancer at a younger age. So I think we have to be very smart, very strategic, and sort of tailor our approach to the patient that is in front of us in a very resource-limited environment.
Wow, thank you. And I also see the hand of Dr. Nadej. So she's gonna, Dr. Nadej, can you introduce yourself and please, and then help me in answering some of the questions?
Well, thank you so very much. First of all, thank you for this. This has been so enlightening, even for us that are practicing here. I am a surgical oncologist in the Pennsylvania area. Will be starting as a surgical oncologist, but I've done a lot of disparity-based research here. So one thing that came out of this brilliant lecture, I agree with Raisa, is the fact, the need maybe for us to start thinking about screening, developing our own screening strategy for those populations. Earlier in the chat, there was somebody who asked if, the GAIR model, for example, was tested and validated in our populations. And, what we know is that in reality, the proportion of African Americans or people of African origin in a lot of those trials is very, it's a very small amount, not enough for generalizable conclusions. So I really think that what we see here, when we look at a median age of diagnosis that is in the mid-30s, we really need to start thinking about how we develop our own risk model and something that can really capture the majority of patients. And I know that we think about resource and we think about cost, but we cannot go forward and we cannot make meaningful changes if we don't start thinking about developing our own screening, screening that is a lot more appropriate for our population. Another thing that I would like to raise is to bring forward is this, and if there's any radiologist on the panel, I would like to hear from them. In that population, knowing that we have, breast cancer or the female breast in the African population is a lot dense. Isn't it better to start really utilizing ultrasound with a combination of other factors, risk family history, clinical, other risk factor, to really maybe come up with a monogram that allows us to detect those high-risk patients a lot easier? Shouldn't ultrasound become, which is a lot less expensive than MRI and mammograms, shouldn't ultrasound become a tool of choice for us in those settings in sub-Saharan Africa?
Yeah, thank you very much, Nadesh. Thank you very much. And I know some radiologists, I'm going to put them on the spot. I'm very sorry. There is Professor Tambe, who is my classmate, and there is also Dr. Dennis, which we work a lot, Chin. These are excellent radiologists in Cameroon. If you guys can chip in, that would be nice. Those are the two I've just recognized. If you can unmute yourself and.
Thank you very much. This is Joshua. So I very much appreciate what Najet is just from saying. My experience as a radiologist when it comes to performing breast ultrasound scans for patients with breast issues, I would like to divide them into two main groups. We have those who come for screening. And talking about screening, it means we are looking for a disease in someone who is susceptible of having the disease, but who doesn't have the signs and symptoms of the disease. Now, it's a bit tricky with screening. Now, for diagnostic mammograms, these are people already symptomatic, and especially if there is a lump. The big problem we have with screening ultrasonographies is when we have to deal with non-mass lesions. So you have a breast cancer, but it doesn't produce a mass. And there are so many of them. I've not laid hands on any study on kind of percentages, but we have so many of these breast tumors, which are non-mass lesions. And these are the cancers that we typically depict on mammograms by identifying a group of microcalcifications. And again, these patients definitely need a stereotactic biopsy. So for many of these patients, ultrasound scans are going to be negative, not because there is actually nothing, but simply because there is no mass lesion, but there are microcalcifications, which are usually very tiny and below the diagnostic capabilities of ultrasound scans. The second problem we're going to have with doing routine ultrasound scans for screening per se is because there's always going to be lack of this, what we call in research, a hindsight bias. If I perform a mammogram and I read it properly and I have to do a complementary ultrasound scan, it's usually a very, very precise and targeted study. So I know that even if I don't find a mass, but there is a specific quadrant where I have to pay a lot more attention. Now, without this information, it becomes difficult to just run a scan like that, except we may have to use maybe an AI model. So again, if it's a mass lesion, it's very easy for screening with ultrasound, but without if it's not a mass lesion, it becomes pretty difficult using ultrasound scan. That's why in the US even, these women with dense breast less than 35, in some centers, they use an MRI scan. I would like to hear from my colleagues also to benefit from their experience.
Anyone else in Cameroon wants to chime in or just say something? I don't know if Dennis is, I'm sure he's still driving, if he wants to unmute himself and say hi.
Yeah, a shout out to Basil, but Basil just gave exactly one of the things I was talking about, an ultrasound AI-based tool for screening. Because if it has to be done by humans without any hindsight of a mammogram, where at least there are microcalcifications and there is no mass, it becomes cumbersome. Thank you, Basil. If you have any more, if you have further information, I'll be grateful to learn from you. Thank you.
Yeah, so radiology in Cameroon, in the US, there's a lot of AI. I think it's one of the departments that is embracing AI more than every other department. So they have very specialized AI tools that they do use in diagnosing medicine. I would have loved to have some other friends I know who are not here, but we'll bring them up to the town hall some other time. This is a special session of the town hall just to discuss this because of the breast cancer week that is ending. So let's continue. We'll be a bit faster in the discussion before we go over to the next session of question and answers. Now, I want to talk about ductal carcinoma in situ. And those who were here from the beginning, I did start in the beginning trying to differentiate what this really means, because a lot of people don't understand what it really means. When we talk about ductal carcinoma in situ, means that we do have, and this is what Professor Joshua was talking about, these lesions don't usually present as a mass. They do present as calcifications. And ductal carcinoma in situ, as depicted here, shows you that there is cancer which is found in the ducts but has not crossed the stroma. Here is lobular carcinoma in situ. We don't treat ductal and lobular carcinoma in situ the same way, but patients with lobular carcinoma in situ do not need surgery, but they are high risk and they need prevention, which we spoke about. Here is a classic question. This is a patient, this is a mammogram showing you multiple calcifications here, but here I'm using it to answer other questions. Here are the calcifications. If you biopsy this lesion, you're going to discover this patient has ductal carcinoma in situ. And here, this patient has multiple lesions. How do you treat patients with ductal carcinoma in situ? These are always very important questions. Should they get a mastectomy or should they get a breast conservative surgery? I'll call it breast conservative surgery because using the word lobectomy, segmentectomy, partial mastectomy is just doing using semantics. Now, the question is, if you do have lesions throughout your breast, there's no way for us getting a 2 millimeter negative margin, so you need a mastectomy. For those who can afford and do have localized disease, you need to get them a lumpectomy. But I think we had discussed this multiple times, even in the town hall. Lumpectomies are difficult in Cameroon because access to radiation is zero. There is the COC that has a linear accelerator right now. Bingo is building one. The L'Hôpital Général has a Cobain machine, which is not even working well. So these are the three areas where they may have access. But how do you radiate all these women? Should I get women with DCIS to go do mastectomies? That's a big question. If they cannot get radiation, this becomes a real question for us to answer. So we know that 1 to 2% of local reoccurrence after mastectomy when compared to breast conservative surgery. Centenary lymph node approach for patients undergoing mastectomy, it's usually done because there are times that we go in when patients have calcifications everywhere and we actually convert them to invasive disease after we take all the tissue out. I've had multiple cases like that. And if you have breast conservative surgery, you need radiation. Even for breast cancer that I'm going to talk about, these policies almost stick. The only difference is that those who have invasive ductal and invasive lobular carcinomas do not need chemo. Those who have DCIS do not need chemotherapy. But those who have invasive disease may need chemotherapy that we'll talk about. So what is a negative margin? I think I spoke about this. I've reviewed over more than 50 pathologies in Cameroon so far. Most of the time, I do not get the report of the marginal status. There are a few situations I've had it, and I've had people who are biopsied, but post-surgery, they have not sent the specimen for analysis. That's even where the problem comes. It's not even with the pathology. They don't even receive the final specimen after the biopsy. And for DCIS, we need a margin of at least 2 millimeters. If it's less than 2 millimeters, we need to go back in and do re-resection. And if we're not able to get that, that's when you get them a mastectomy. The question becomes, are we able back home to even identify these margins? As I told you, my personal experience has been very difficult in Cameroon after getting multiple consults. And as I said, I'm sorry to those whom I did not respond to their consults. It gets overwhelming at times. So now, do we even have, so now do all breast conservative surgeries need radiation? We have had multiple studies. For the sake of time, I'm not going to go through all these studies, but the final conclusion from all these studies is that almost everyone benefits. Those who have lumpectomies or those who have partial mastectomies, depending how you call it, those who have segmentectomies, all of them do benefit from radiation. And here, that is the first thing I want to talk about. And now in Cameroon, we do not have access to radiation. The second thing so what do we do going forward? Should we be doing DCIS patients or get mastectomy? That's a whole ethical question. And I think we need local solutions for local problems. Now, do all women also, do they need hormonal treatment? We have had multiple studies that have actually done research into this field. As I told you before, we've had multiple studies, and I did tell you that we've had studies called the NSABP. The NSABP actually means the National Surgical Adjuvant Breast and Bowel Project. So the B24 was the first study that did show us that by giving these women tamoxifen, we improve their overall survival. So all of them need hormonal treatment, those with DCIS. DCIS is very rarely diagnosed in Cameroon just because we do not have access to mammograms and we don't do it routinely. So the rate of DCIS noted in women is very low. Do all women who have DCIS benefit from tamoxifen? The answer is no. Those who benefit are those who have positive hormonal status, those who have ER positive disease or PR positive disease. Those are the patients who do benefit. Those who have ER and PR negative disease do not benefit. DCIS patients do not need a HER2 testing. So here was also studies to show randomized for aromatase, for aromatase inhibitors. Here you could see that they were actually also positive. So for women who are postmenopausal, you can actually prescribe them anastrozole, letrozole, or exemestane. And here we can see that all these women actually benefited, especially those who were age less than 60. So these are overall survivors. And just in summary, when we have talked a lot, when we're talking about DCIS, in our Cameroonian setting right now, DCIS diagnosis is rare just because mammograms are not a routine practice. We do use mammograms when we have breast masses most of the time. We don't routinely screen. And should we do a mastectomy for all women or should we do breast conservative surgery? I would want to do breast conservative surgery. Now, should all those women who do breast conservative surgery get radiation? There is a benefit for radiation, but we can actually spare that in our setting because we don't even have access to it. Those who have access to it should get it. And women should be placed on hormonal treatment for 5 years, either tamoxifen or aromatase inhibitors. For those who are postmenopausal, they can get tamoxifen or aromatase inhibitors. And when there is residual tissue, for prevention only. So if you do a woman who you do mastectomy and there is no residual tissue, no need to place them on aromatase inhibitors. Now, we are moving to the last section of our discussion today. The last section of our discussion is going now into breast cancer. All what I've been talking about, I've not gone into really invasive breast cancer. The questions I'm going to answer today are going to be, should we do mastectomies in Cameroon or should we do breast conservative surgeries? Post-mastectomy radiation, is it something that patients benefit from? Should everyone with breast conservative surgery need radiation? Axillary lymph node evaluation, what do we know? So how is breast cancer treated? Breast cancer, I'm going to hammer on this in Cameroon because I studied in Cameroon. We don't have a culture of collaboration. We're trying to create a culture. Why should you want to give patients chemotherapy let's say somewhere in DOP, when you do have people in bingo who are giving it efficiently and they know how to do it. You should refer them. You may do the surgery, you guys should collaborate and do the things that are right for patients. Oncology is one of those fields that depicts collaboration. Breast oncology, breast cancer is one of them. In breast cancer, I always say, when I tell my patients, I'm one of the team members, okay? At every stage, there is a new pilot who is going to pilot your plane. You are the plane, there's a new pilot. In the beginning, if you're stage 1, I'll allow the breast surgeon is going to pilot it, take you over, get you surgery. We'll do testing. If it happens that your hormonal status come back, which we'll discuss tomorrow, and you're HER positive or you're triple negative, they're going to send to me. And I would provide you with neoadjuvant therapy. I'm going to be the pilot for that period. Once I'm done, I send you back to the breast surgeon. The breast surgeon does the surgery. And let's say the margins, you had a complete response. We are going to send you to the radiation doctor who is going to do radiation after your lumpectomy. And after finishing with radiation, you're going to come back to me and I'll do surveillance throughout your whole life period. This is how cancer management should be done. There are multiple modalities and multiple things we can do. This to me, I'm going to still present this tomorrow. This to me is the most important slide in breast oncology. The most important, if there's any take-home message, this is the slide. Once you have a patient who has breast cancer, we do know in Caucasian populations, about 70 to 80% of them are ER positive. In African population, that number drops to between 60 to 50% after studies, or 60 to 70% after studies that have been done in Nigeria and other places, and Kenya and South Africa. But Africans are so heterogeneous. We have the most diverse genetics. So even doing something in West Africa doesn't mean that's the same thing that's going to happen in South Africa. And we do know that about 15 to 20% of them are HER2 positive. And we know triple negative is about 15 to 20%, but in Cameroon and in Africa, we tend to see higher levels of triple negative, and in Blacks, even in the US, ranging between 20 to 25 or even 30%. So why should, I just spoke about triple negative. I brought this slide here because it's an important part of our discussion we'll talk about tomorrow. And we have a higher tendency in having triple negative patients in Black population, slightly higher compared to other races, and we have not studied ourselves very much. So I'm encouraging all the medical students here, get yourself engaged, get yourself supervisors back home, and let you guys study breast cancer. Why is treatment so important? This algorithm, I was very sickened by multiple, not the people who are here, but there are multiple other patients that I have seen, especially in Yaoundé and Douala, where there is solo practice. Like my friend I presented at the beginning, who is the motivation for all this presentation, who had breast cancer, who had early stage breast cancer, but no one did their hormonal status, and she was wealthy enough. She was working in MTN, she had enough money to do anything that was possible. Why? Because even in the neoadjuvant setting, the treatment depends on what type, the hormone. If you want to do one test, they have their last 100,000 to spare. Please do them ER/PR status and then wait. Why? Because once you have a patient who is triple negative, the only things that work is actually chemotherapy and immunotherapy that can be considered in the neoadjuvant setting. We don't have immunotherapy in Cameroon, but at least you know that these are the things I have to do for these patients. If they can afford it, you can send them over to Turkey, India. We can actually have investment. We can get some of those drugs. If these patients are ER negative and HER2 positive, they need HER2-directed therapy, and Bingo knows how to get Herceptin and also pertuzumab and trastuzumab. They are expensive, but if they can afford, at least you provide them with the right treatment. If they are part of the 70% of all breast cancers you guys would see, and they do ER/PR positive and HER2 negative, their main treatment is hormonal treatment. They must have hormonal treatment plus or minus chemotherapy. In Cameroon, we don't do the oncotype, but at least there are models which include the Ki-67. You can use that for risk stratification and determine who needs chemotherapy or not. And these are ways you can actually help these patients. For those who are ER/PR positive and HER2 positive, they do need both endocrine, chemotherapy, and HER2-directed therapy. This helps you. Majority of your patients will fall here. Majority. So you cannot practice breast oncology without having this. If there are investors here, I know a lot of doctors here who are very wealthy, who are in the call. Maybe we need to go back home and invest in getting immunohistochemistry available, a good lab where you must not send it over to France from Central Pasteur or send to the US. And maybe we may help Bingo in order to set up their lab for them to be able to do IAC. It's going to help oncology, and it would also help nephrology very much. So, HER2-directed therapy in breast cancer, you need to be able to know some of these things. We'll talk about this tomorrow. This is just telling you about the different kinds of treatments we have in breast cancer. They are targeted treatments. Here is in the metastatic setting. These are all the drugs that are available. But this is going to be a talk for tomorrow. Now, mastectomy versus breast conservative surgery for those who have metastatic disease. This is a debate I've had with those who are in Cameroon, and it becomes very funny that we can still have the debate. Dr. Kenne, my recommendations in Cameroon has been that those who have breast conservative surgery should get mastectomy. And if reconstruction is possible, they should do it. The reason why is because breast conservative surgery is not people have not been well trained into doing breast conservative surgery. Most of those who do breast conservative surgeries, they are gynecologists, and the breast organ is very much complicated. In Europe and in the US, you have subspecialty in that, and doing breast conservative surgery, you need to send the pathology and be able to tell you if you have negative margins. So far, I've seen very few pathologies that have been adequately interpreted. Now, lumpectomies are things that people can do. These are the different types of surgery. Simple mastectomy, modified radical mastectomy. These are things that we are discouraging. Prophylactic mastectomies can be done for those who have BRCA gene 1 and 2, PAB genes, and those who have leaf framini and other things. Mastectomy with reconstruction, if we can do that, there are several hospitals doing this in Cameroon. Centenary lymph node biopsy is a tricky one in Cameroon. Axillary lymph node dissection is done a lot, which we'll talk about. Here, this is the father of radical mastectomy, those who know Halsted. So it's called the Halstedian philosophy. If you've never heard, I'm a fan of the history of medicine, okay? I read the history of medicine like nothing else. Halsted was trained in New York City and did his trainings back in New York City in the 18th century, the late 18th centuries, and moved to Johns Hopkins. He was the father of breast oncology. He actually revolutionized the way we do several surgeries. The word radical did not mean that he was doing something radical. It actually means rooting out cancer from its roots. So he invented radical mastectomy, which some of my attendings still do that in Cameroon, and they want to defend it. Radical mastectomy was done, and Halsted had multiple challenges. The first challenge he had was from one of his students he trained at Johns Hopkins, who taught a simple mastectomy. Why don't we do clinical trials in oncology? That was his question. Let's just randomize patients, get them radical mastectomy compared with simple mastectomy and see what is going to happen. Oh my God, we were shocked. This was when Halsted was carrying out surgeries in Johns Hopkins. You could see this. Everyone was there. Everyone is looking at it. This is how deformed these women became. And they all had lymphedema and all of that. They took out both the breast, the pectoralis major, took out all the lymph nodes, and they thought they were eradicating breast. But some of them still had reoccurrence. That's what shocked them. This is what we call, this was the ultimate blow to the surgical ego in medicine. The surgical ego is that you cannot radically remove cancer by surgery alone. So now we go into what do we do? We realized if you go into the history of medicine, which I don't want to go, you would see that there were clinical trials that compared radical mastectomy with simple mastectomy, and at the end, simple mastectomy was okay. There were clinical trials that compared simple mastectomy with axillary lymph node dissection with breast conservative surgery with axillary lymph node dissection, and showed that breast conservative surgery plus radiation is equal to mastectomy. And that is why standard of care right now is for women who qualify to get breast conservative surgery with radiation. But in Cameroon, are we able for all these women to afford radiation? Radiation is expensive. Only one cancer center in Cameroon right now, as I'm speaking, provides standard of care radiation. That's the COC. There's no other place that provides standard of care radiation. The L'Hôpital General has multiple brilliant radiation oncologists, but they just do not have the right machines. They have the Cobite machine, which is very, very, very archaic. And it's broken all the time. At times, it causes patients more harm than good. So, and I think Bingo is going to get one soon. They have a radiation oncologist who is very good, and he's waiting for his bunker and his machines to be built. So mastectomy versus breast conservation, we can talk about this all the time, but randomized trials have shown that they are equivalent. But now, how do we adopt this in Cameroon? How do we decide on what to do? It's a very tricky question. I find myself difficult to really answer. Should I be doing mastectomies and taking every woman's breast who has stage 1 cancer? Stage 3, I'm not going to doubt I'll get a mastectomy in Cameroon without any blink because they are not going to get radiation. Stage 2, maybe stage 1, I may decide to do breast conservative surgery, try to get them for radiation and place them on hormonal treatment. If they cannot get radiation, that's fine. But that's just adapting. Absolute indications for mastectomy, inflammatory breast cancer after you have given some treatments, which could be chemotherapy or you could also do hormonal treatment plus CDK4 inhibitors. Multifocal or multicentric disease need mastectomy. Persistent growing positive margins need mastectomy. Diffuse suspicious of microcalcifications in the breast needed. Homologous patients who have particular genetic who are BCR able, who have BRCA genes, who have ATM genes, who have PALB genes, those are patients that you can do. Pregnancy that cannot be, radiation cannot be completed. Those are all special cases. I was planning on discussing that tomorrow, but we may not have time for that. Then there are also relative indications, those who have scleroderma, those who have had previous radiation to the chest wall, those who have had positive margins, women who have suspicious genetic disease like in Cameroon, but you don't know, like every family member, but they have not been tested, those will live from it. So the summary of the approach we're doing back in the 60s, that's where a lot of surgeons, I trained in Cameroon, so I was trained by very big professors. A lot of them are still left in the Holstasian policies of cancers. A lot of them are still left behind because there is no continuous education. Radical mastectomy, that's what they do, but you should not be doing that to anyone anymore. Where we are in the 2000s is opting for women, including reconstruction and breast conservative surgeries. We have a lot of surgeons in Cameroon who can do reconstructive surgery in Yaoundé and Douala. Centenary lymph node biopsy should be standard of care and should be instituted in all our cancer treatment centers. Where are we heading to from 2023? We are de-escalating surgery, less surgery, capitalizing on multidisciplinary approaches. And that is why you as a surgeon should not sit at home, sit in your office and think you can treat cancer alone. It doesn't work that way. Now for axillary lymph node evaluation, these are the complications we don't want to see. We don't want to, all women used to have axillary lymph node dissections. And it led to multiple complications, lymphedema, shoulder dysfunction, paresthesia, pain. And we do this a lot in order to have adequate staging and plan for chemo and systemic therapy and radiation. Now, centenary lymph node dissection should be standard of care. Standard of care, especially for those who don't have a positive lymph node when you're seeing them. Now, how do we adapt this in Cameroon? How good is this technology? The props are easy to buy. You can easily get the dial and you can easily get the radioactive ingredients in order to use. We use 2 of them done in the theater or during surgery, and they're able, the centenary lymph node is the first lymph node that is positive, and that lymph node is taken out and we test it. If there's no cancer there, we don't go further. That's just what is done. We use tracers such as there are several of them that can be used. And then we use the isosulfan dial and we inject in the locations. In the beginning, I had some questions. They can be peritumoral injections. They can be subareolar or subdermal. And then we look for the most common or the lymph node that is going to light up. So there have been multi-institutional registries that have shown that single agent, dual and double agents has actually shown that using a double agent would be better in these patients. Now, our next question is, in this study is, should we Centenary lymph node followed by axillary lymph node compared to axillary lymph node dissection in patients with lymph node negative. So the conclusion is that once your lymph node is negative, you do not need, please, you do not need to do axillary lymph node dissection. That is now standard of care. There are multiple trials that have done this, and we do know that that is the standard of care at the moment. Now, for patients with positive lymph node, that is a whole different ball game and a whole different story that we're going to talk about. And we'll be able to talk about that very well once we start talking about treatment tomorrow. I've kept you guys here for more than 2 hours, and we'll just do a little adjuvant breast radiation. All patients do need radiation to the breast. Those who are above 75, you could also de-escalate radiation, but all patients do need radiation to the breast if they do have breast conservating surgery. Using radiation therapy, these are, in Cameroon, we have just one linear accelerator, as I said, and here you can see exactly how it's done. It's pretty safe. A lot of my patients are actually scared of radiation more than anything else. It always puzzles me, it's just because of the way they are being told and what they are told by others. But in Cameroon, the accessibility to this is very limited in the first place. And it's just really a field where we need to invest a lot. So radiation and breast conservative surgery, once you get patients do breast conservative surgery, all of them do benefit from radiation. There are multiple studies that have shown that. And here are some of the studies showing you the benefit from reoccurrence and even overall survival, the benefit. So this is becoming standard of care. Here is just elderly patients you can actually de-escalate. And some of them you can actually, comparing elderly patients by giving them just a boost that's low fractionated treatment, at times they do still benefit. So these are all things that we do in oncology right now. And at the moment, our goal is for us to be able to understand and have a take-home message, which I want to pass across. For me, the take-home message is very simple. We should be able, in radiation, whole breast radiation should be what can be done in certain circumstances. Chest wall radiation, including the breast and reconstructed areas, and regional lymph node irradiation and addition. If the lymph nodes are positive, you need to do radiation of the lymph node area. Post-neoadjuvant radiation decisions should be made on the highest stage and clinical, and we should involve the clinical radiation oncologist. So as let me see here, yeah. As a conclusion for breast conservative surgery versus mastectomy are all equal for early stage breast cancer. Early stage breast cancer, if you're doing breast conservative plus mastectomy, the question is majority of our patients are actually stage 3 or stage 4 in Cameroon. So at times they may need mastectomy and axillary lymph node dissection. Breast conservative surgery is feasible for large primary tumors and locally advanced breast cancers after preoperative systemic therapy. That's something we can do in certain circumstances. Even if you're hormone positive, we can decide to give you chemotherapy and then downstage you or give you hormonal therapy with a CDK4 inhibitor. We can do that too. Centenary lymph node biopsy is an alternative for axillary lymph node biopsy and reduces side effects. Selected patients with positive centenary lymph node can omit axillary lymph nodes. Here is just another, just for local reoccurrence, which we'll talk about again tomorrow. And during this was my first question I asked when I started the presentation. All of the following increases a woman's risk of developing breast cancer except prior biopsy showing a typical ductal carcinoma, a typical ductal hyperplasia, LCIS, DCIS, they all increase risk for breast cancer. Obesity also increases risk for breast cancer. Alcohol consumption increases risk for breast cancer. Breast implants do not. The next question was, breast conservative therapy is a proven alternative for mastectomy in the treatment of multifocal ductal carcinoma in situ? No. They have multifocal disease, they need a mastectomy. Localized early stage breast cancer, yes. Patients with poorly controlled systemic lupus erythematosus on active treatment, yes, it becomes difficult for you to actually radiate them. Patients with scleroderma, same thing. Patients with positive margins following lumpectomy need to get a mastectomy. Sometimes that's a debate. You can always do that. All of the following are true with respect to centenary lymph node surgery, except which of the following? Tracers can be injected in a subareolar or the peritumoral location. That's true. It is not associated with risk of lymphedema. It is. There is still some risk of lymphedema even when you do a centenary lymph node biopsy. There is upstaging of patients through detailed pathological assessment, yes. And that's what we have said in Cameroon. We need investment in pathology. Selected patients with a positive centenary lymph node can avoid completion of axillary lymph node. That is true. The next question I asked at the beginning was, a 55-year-old premenopausal woman has recently had a breast reduction surgery with an incidental finding of classical lobular carcinoma in situ. You would recommend which of the following? Please take home message. Lobular carcinoma in situ do not need surgery. You can give them exemestane. No. They are premenopausal. Prevention, you don't use exemestane for premenopausal women. Roloxifene was not studied in premenopausal. Unilateral mastectomy, you're overdoing it for LCIS. Tamoxifen, yes. Our next question is, this same patient is started on tamoxifen. After 5 years, she is premenopausal and no other breast events. You should, one, extend tamoxifen for additional 5 years, please. No. You do that for patients who have had breast cancer and they are high risk, not for patients who have DCIS. Switch for LCIS on prevention. Switch to anastrozole and complete an additional 5 years. No. Discontinue endocrine therapy. Yes, that's what you should do. A 57-year-old woman has DCIS with microinvasion. There is no link, there's no ink on the tumor. Is she considered to have adequate margins? The answer is no, please. For DCIS, that's a whole debate. That wonders me. For DCIS, the clinical trials, they need to have 2 millimeters wide margins. For cancer in itself, they just need no ink on margin, on tumor. But that's a whole discussion for another day for us to have. Tomorrow, we're going to talk about management of metastatic disease. We're going to talk about treatment of breast cancer. How do we treat breast cancer? What are the reasons how we treat breast cancer the way we do? And we'll talk about survivor. We'll talk about what are the treatment options, who are those who are going to be involved in the treatment. And our goal in Cameroon is for us to help our patients survive longer. Now, I did know, I put in this, Cameroon had a national plan for prevention of cancer. This was a national cancer strategic plan that was done by WHO, Clinton Foundation, and many other partners. The sad story is that nothing has been done. We're almost done with 2024. Not much has improved. At the time, the highest incidence of breast cancer in Cameroon was found in the Northwest region. Who knows why? This is pure public health. It's because the best cancer treatment centers are all in the Northwest, so they're getting screened. Bingo has 2 or 3 regions. They're getting screened. That's the reason. And all the areas where there's screening, you have high cancer levels. So this is the central region has some few, but central region is also big without access, littoral, and then Northwest, and then West. Everywhere else is low. It's just telling you that this is a bias, screening bias. So human resources since 2018 has improved. There have been more training of radiologists. There have been more training of oncologists, and there have been no training of radiation oncologists in Cameroon. I know 2 of them that were trained. They were all my classmates that went over to France and went to abroad and got training, came back, and they have not been used in the right way. One person has been in L'Hôpital Général Yaoundé without a machine functioning forever. And it's just sad that we do train human resource and we don't use them at times, and we don't even have enough of them. But there is some improvement going on in terms of this. There are multiple sectors in Cameroon that are really lacking. If you really want to talk about In Cameroon, we have gotten in a tendency of training physicians, and we are not training the auxiliary members that have to work with physicians. We train oncologists, we train others, but we don't train subspecialties in nursing that have to work. There are no oncology nurses schools. There are few, or they are known, but the government doesn't invest in that. We train radiation oncologists. We have trained few, but we don't even train physicists. We don't train dosimetrists. We don't train anyone else who's going to work with them. So there is limitations in terms of palliative care. There's just limitations in a lot of things. Here is diagnostic imaging in Cameroon, where they are found. Right now, there have been some improvements since the African Nation Cup. There is an MRI, I know, in Bafoussam. The ones in Yaoundé, some hospitals are working now. And up north, there is also one in l'Hôpital Général, Douala, Amal Garwa. But it's just parallel. What is sad is that you have the second level of care have MRIs when the first levels do not. Like l'Hôpital Général Yaoundé, the MRI started functioning recently. Their MRI was not functioning. CHU doesn't have an MRI, but you have the CURCs they do have MRIs. I don't understand how investment is done. We need in Cameroon to understand that when we say something is a referral hospital, we should treat it like one. But it's just a whole discussion that we can have some other day. These are facilities that offer chemotherapy. They have not changed much. These are still almost the same facilities. You realize that a lot of them, you have Yaoundé, l'Hôpital Général, Douala. And how do you train oncologists without training where they don't work multidisciplinary sectors? There's no radiation oncology. So even understanding what radiation oncologists can do becomes a whole difficult aspect for them, those who are trained back home. Because if they are not working with them from time to time, they don't have breast surgeons, they don't have pancreatobiliary surgeons, they don't have others. They turn not to see the benefits of what others offer, and they don't see the importance of multidisciplinary approach in treating cancer. So going back, these are the cancer centers that are found in Cameroon for now. You see majority of them are the Baptist Mission. Baptist missions have in Bingo, in So, in Motengene, in Bopi, you have Fondation Chantal Biya, then you have our l'Hôpital Généraux. Here, I did not forget the Cameroon Oncology Center. Those who were here at the beginning, they were telling me that it exists. It exists. I know what they do. And I know Professor Paul very well. So he's been doing a great job. This is the linear accelerator. This is not an advertisement, but this is the only machine that we have that is capable of doing what a radiation oncology machine should be able to do now in the 21st century. Now, when it comes to Cameroon and the capacity, Cameroon's capacity to control, we have no national cancer screening guidelines available. Which cancers do we screen for? We do screen for cervical cancers in Cameroon, and it's done. Is there a guidelines? No. We do screen for breast cancer, but is there a guideline? No. We don't even screen for other cancers like colon and the other. Chemotherapy is available, but it's limited in limited centers. Radiation is available, but just standard in 2 centers in Cameroon, but just 1 is standard of care. The use of opioids is very sensitive in Cameroon, and availability is very poor. Majority of the time, you find it just in mission hospitals. Cancer screening guidelines, here are some of them that we should take note of. This is just an aside before we end the lecture, and be able to really get to prevention is better than cure in Cameroon. That should be our approach. The goal of the first part of the lecture today was just for us to get to understand breast cancer, train the GPs well. And next year, I'm looking towards collaborating and doing this lecture with many others who are here. Raisa, you're here, and Nadej, and many others, even those back home, so that I want I've done this for the past 2 years, and tomorrow we'll have another lecture, but this, to me, the most important cancers, during the months of the cancers, we want to provide training, especially to young physicians back home, the GPs in particular, and also update knowledge on the others, and we'll try to get a CME credit. So thank you, everyone, and question and answer time. You can unmute yourself. If you have any questions, please. Don't wait. You can raise your hand, you can unmute yourself, and then we can talk. We have additional, those who are very busy, you can always log out at any time. We have additional 30 minutes just to discuss a few things.
Thank you once more, Dr. Munoh. It seems to be I'm the one always first talking. Yeah. sincerely, after listening to you, I think that we have a long way to go in Cameroon. And if I were a cancer patient in Cameroon, I would have been disturbed after listening to this lecture. What simple message can you give to such patient at this point? And second question is, you know, our government, it seems to be they are trying to do their best, but it seems to be the best is not good enough for now. Because imagine even malaria, that is the #1 killer infectious disease, nothing has been done so far by the government. We still depend a lot on external funding. And coming to cancer now, you know that it will be difficult to get this funding. So what can you tell the government for now to put as an essential platform to take care of this patient so as to reduce the severity of the infection? And also, what can you tell, because there are many diaspora who are also listening to this and who may want to invest back home, what do you think should be the area, or what can be the first line of investment that they can do in helping the government out in such a situation? Thank you.
Yeah, thank you very much, Dr. Maloba. The truth about it is that patients who already have cancer in Cameroon, we need to provide support. We need to invest in palliative care. We need to provide them with adequate medications that can help control their pain. We need to get advocacy and provide hope for some of those patients, especially those with stage 4 disease. Hope, meaning that we should get in such a way that we can, as a population, as a group of people, invest in trying to help the system build in such a way that we'll be able to take care of this patient. That's a very difficult question, what to really tell them. It all depends on what kind of cancer they have. If, like as I told you in my presentation, 70% of them would have, if their breast cancer is going to be estrogen and progesterone positive. And just by giving them tamoxifen at times, we can do a lot. Anastrozole is found in Cameroon and is not very expensive. Letrozole, exemestane, and tamoxifen are all found. We should know their hormonal status. There are many other cancers that have good prognosis, and there are some that have really bad prognosis, even if you are in the US. So those are all things that we should be able to train our GPs to help, which I'm going to move to the second point, which is not going to help the cancer patient, but help everyone, to help in screening. Where we are in Cameroon, I hate to group African countries as one because we're very different. What's happening in South Africa is light years away from what's happening in Cameroon or Kenya, their approach to things. So we should be able to train our GPs and make sure that they are truly the guardians of the healthcare system, where they take priority in screening, especially in cancers that screening have been proven to help improve mortality and reduce the incidence. Breast cancer, prostate cancer, those who are smoking with lung cancer, colon cancer, these patients should be referred, get themselves screened so we have early diagnosis, early treatment, and get prevention in place. Now, what do I tell the government? The government of Cameroon has multiple problems. I'm also a public health specialist, and I'll tell you, if I was a minister, I don't know exactly what I'll prioritize, you understand? I don't know what the Secretary General is going to prioritize. He's in a very difficult situation. He has malaria that is ravaging everyone. He has children that are dying from simple pneumonias. He has vaccination that he has to do throughout the country. He has limited resources because he's a third world country. He has tropical diseases that are happening. He has TB, he has HIV. Now, as the medical field, if we really think cancer is a big problem, we should research and show that it is. But what I would advise the government to do in its national strategic plan is should have a plan in place for prevention. Prevention is better than cure. If the government wants to invest, the money the government would invest in curing everyone will be very little amount of that money will be used for prevention and would save hundreds and thousands and millions of lives. So if I was in the government sector today, I'm going to invest, my funding is going to go for screening. Now for the diasporans, there are a lot of diasporans that are doing wonderful things. Last week, we had Dr. Sidney Taze, who is a physicist in the US, in Florida, Tampa. He's actually the founder of Clear Radiology in Boya, and they do a lot of screening. There you have mammograms, there you have all the CT scans are available, and he does free screenings, and also people in the diaspora get to pay. There are multiple other diasporans that are engaged in creating clinics. Multiple of them, I cannot call all of their names here, but there are so many of them that are investing in that, but they should invest in screening. Their platform should be a screening platform. I have multiple millionaires who are in the US here, who are doctors. I would advise them, if Dr. J. Bazil is still here, they should always invest, go back home, let's invest in screening, colon cancer and every other thing. There are people in the diaspora, such as Bazil, that are giving back. They are doing projects with the, I think he has multiple projects with CSU and multiple other places. There is Alan Tita. There are just so many Cameroonians doing a lot in different fields in the diaspora. We should just encourage them and get them to do what they're doing. I know a certain Cameroonian who goes back home and does surgeries in orthopedic surgery. So these are all things, the diasporans, we should also invest in education in our young generation. Partnership with different universities that are open to it. There is Boya University, there is Bamenda, there is Chang, there is Douala, there are all of them. Let's, in the diaspora, if you have a particular talent, you should collaborate with those homes, and those homes should also be ready to collaborate with you and be open. Now, I think going forward, to me, is always prevention, 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 nothing else. If anyone has something else to add, you can always unmute yourself. Now we are just having a discussion. You can unmute yourself and
thank you, Dr. Munoh. My name is Comfort Tekang. Thank you for that wonderful presentation. I really appreciate what you do, and thank you everyone for being here. I am a hematologist and oncologist at the University of Minnesota. This is my third year, my final year, and appreciate what you're doing, and hopefully join you all to do this great work. Sat through your presentation and it was very educative. Thank you so much. I just want to say, more recently, I was in Tanzania, January of this year, along with some oncologists at my program director. And really the goal for that trip was global oncology. I am interested in global oncology myself, and I wanted to learn some more about how to support the work globally. And one thing that backed me, the main goal for the trip was to establish a radiation oncology unit in the area. It's somewhere around Mount Kilimanjaro, and they had issues with radiation oncology. And I would say during the course of the trip, it dawned on me that there was a lot of advances in the oncology field in other African countries that we weren't benefiting from in Cameroon. And listening to your lecture just helped me realize how big the disparity is even in Africa. One thing that I took from there was prevention, like you rightly said. Most of the times, if we could educate even our own community, starting from people in the diaspora, because sometimes we get these phone calls from family members about issues like this and no guidance. I had a friend wait for about 2 months to get immunohistochemistry results from France through Centre Pasteur, and that delayed her therapy significantly. And eventually, when they found out that this was HER2 positive cancer, it was now metastatic. It was no longer eligible for surgery. And unfortunately, she recently passed away. And so just knowing that this can be done in bingo, I don't know what the turnaround time is for that, but having this information go around can really save lives. And fighting to try to get more of these things done in more parts of Cameroon would really go a long way. So thank you for all you do, even educating your family members, your friends in the diaspora and those back in Cameroon goes a long way to help people so they know where to find some of the care that they need.
Wow, thank you very much, Dr. Takan. And it's always a pleasure. We're happy to, there are many organizations in the US, please join them, okay? There is, I don't know if you're part of the Cameroonian physicians or the organization, join all the organizations. We want Cameroonians who are there, who are going to be able to, we can partner and do a lot of things in Cameroon. That's what we're looking forward to. We can partner, do a lot of things in Cameroon going forward. I always, though I'm presenting here, I have the town hall that I've been doing for many years. Our objective is not just cancer in the town hall, but I always encourage all physicians that are here in the US to join the ACPA. If you're not a member, you join. Why? Because it's where we can also, as a group, put our resources together and actually help. Those who are pharmacists, let's join the organizations that are here. They're doing a wonderful thing. Those who are, there's also an organization of Cameroon anesthesia nurses. They are wonderful. They have done marvelous things in Cameroon, like you cannot even imagine how much they have done. I do know their president and others. So let's group ourselves and try to see where we can actually impact. It could be just education. I've been doing the town hall now for 4 years. It started because of COVID. I was in New York City at the time, and I saw the death. I was in oncology. I was a fellow, but I saw the number of people dying. I was like, oh my God, how do we do this? We stopped and all started doing COVID. So we started a town hall, so we're going to educate people. I was here. I have a colleague, one of my classmates back home, Professor Titanji Poguma. So we all did that. So let's thank you for what you do. Let's also, what you learned once you traveled over to Kenya, what you learned there, let's see how we can implement it. I hate to group African countries. I've traveled a lot in Africa. We are not the same. And once we group and say everything is an African problem, is not. There are problems that are specific to particular countries, to our country, Cameroon, which is very peculiar. We are better than others, but we should not contend with that. But South Africa and East Africa, they are light years away from us. Light years away from us. So thank you very much, and thanks for all what you do. And we're looking forward to collaborating with you, okay? Yeah. And for future lectures, maybe some other lecture, prostate cancer or something else. And yes, Dr. Nadej, you can unmute yourself.
Yes, I just wanted to, in light of, all that we've been talking about, is there a way to really map all of the resources in Cameroon? Because, what the doctor just said was, it's really disheartening to know that, a provider, let's say a provider in Douala may not know where the, working radiation centers are. Is it urgent for us to at least have a map of where, the resources are in each province so that people know, and so that, we can really, patient can be referred in an effective fashion. The other thing, coming to your education, is it also possible to have a sense of what procedure surgeons may need? I'm talking mostly from a surgical oncologist standpoint, right? What are procedures that are done routinely there where they may need assistance or education? And this is vice versa. I don't really think that we come from the diaspora and then teach people how to do things. But I think that we, if we are collaborating from an educative standpoint, we want to know what the need is. So if we could have a list of those things, I guess that could give the basis for really starting to make meaningful collaborations.
Yeah, wow, wonderful. This is Dr. Nader. This has been the last town hall. This was the same question. And I don't know if Dr. Erwan is here. That's one of my classmates. He's a surgeon back home. And we spoke about this, and the conclusion was that when it comes to mapping, we do have data that was released at a certain time, I think it's 2018, by the National Medical Council, where they had doctors where they were, but they did not have and their specialty, but they did not have what capacity, what they could do. There were pulmonologists that were cited, but we don't know if these particular ones are critical care. Can they intubate patients in their hospital? What can they do? Oncologists that were cited. So what we need to do is actually, as a group, I don't know who's going to take that up. And we're discussing as a town hall, the last town hall we had, to finance that kind of a project where we can map the country overall, what specialists are where, and what do they do? Because there was a big question during the last town hall. There was a patient who had a lung mass. Who can do an e-bus in Cameroon safely? That was the big question that was asked. Someone asked. We did not even know. Who can do, who is the interventional radiologist who can actually biopsy that patient safely? Are we able to know that? Who can do a safe colonoscopy with interventions and resections of polyps, not just do a colonoscopy and leave? These are all things that we need to, as a group, decide. It's not available. Put in some little money, get someone in Cameroon, do research and map that out. So I think that's a good project. We can actually do it. It's a project we can actually decide and do it in different our different groups. I think I'm a big advocate that as a group, even at the ACPA group, we can actually do projects like that in Cameroon, which can help the diaspora to actually know what it is. And in that same light, we can actually get to understand the need. Meaning, if we can do a research, we can understand the need of the surgeons. What can they do? In Cameroon, I'll tell you, subspecialty in surgery, there are isolated people who have subspecialized, but the government doesn't really provide those subspecialties. I don't know if there's any pancreatobiliary surgeon. I don't know if there's any breast. There must be. I don't know if there's any breast surgeon who was trained as a surgeon. There are gynecologists. Professor Doe used to be trained as a gyne oncologist. I don't know how many of them are now gyne oncologists properly trained through a residency or fellowship program. I do not have that data. And these are all data that are missing. So we have data missing in multiple places. How many people can actually carry out a Whipple's procedure safely in Cameroon? How many of them do? They do in L'Hôpital Central mostly. Are they trained? What is their mortality level? So these are all things that I think we don't have an answer, but we can invest in. We can actually collaborate also with the National Medical Council to see if they could help us, and we can finance something like that and get data that can help us grow. I don't know if anyone else, Irwan was here, he left, most likely, or you can unmute yourself if you have answers and you're in Cameroon. We had multiple people after the lecture, some of them left. And there can be collaboration. I see that Professor Hale is still here. He's actually the Dean of the Faculty of Medicine, and we're looking towards multiple collaborations, even with the ACPA and even the town hall. So maybe Prof. Hale has something to say. We all know him very well.
Yes, thank you, sir. We also know you very well, and the people who are assisting. It's encouraging to hear you speak all the time. We have been talking for almost 3 hours now. We wonder where you have this energy. We're impressed. And if it's a collaboration, I want to thank you for citing us, because we think that is the future. And it's not only at the national level, internationally, we have gained a lot. University of Boya, and specifically the Faculty of Health Sciences, we have partners from Arizona, we have partners from Africa, Tanzania, we have partners from Pennsylvania, we have them everywhere. And we have the most important partners that we have are real partners we see like you. When we see the motivation of your colleagues and all that you carry along, all the time you spend, it cannot be. It's very, very rewarding. It's very rewarding. And this multidisciplinary approach is, I think if we are lacking something, is this multidisciplinary approach, as you emphasize. It's a spirit that has to grow, and really will have to emulate your efforts you are giving in, and those of our colleagues there who are in the diaspora, to pull us along, to have this spirit of collaboration among surgeons, whether it be them oncologists, internists, and whatever. We have to lose this tendency of being sitting on patients, if I might sit, because that is not the aim. When collectively we take care of patients, I think it's more rewarding. I think those are the few words I have. And if you continue with this spirit, most of us will benefit from your experience and those of others. So thank you very much. We really appreciate it.
Thank you very much, Prof. And please, if you can send me your number privately, I'll be very grateful because we're going to look at how we can have, I'm a member of multiple other organizations, the ACPA, which we may want to collaborate and do certain things, educational lectures, certain things in Cameroon. We've been looking for people whom we can collaborate. ACPA is the American and Canadian physicians that are here in the US. And we have a very dynamic leadership. They really want to influence things in Cameroon, and they want to work with people whom will provide them an environment where they can collaborate.
Okay, thank you, sir. That will be done.
Thank you very much. I'll be very grateful
Yes.
to.
In the last 2 months, we have colleagues from Arizona, we have colleagues from UAB, we're expecting some from Barara in Tanzania and Uganda. So you see, our hands are open.
Good. And others, I will be in Cameroon in maybe, I think I'll be in Cameroon in May. I'll let you know, and I would love to come over. I did study in Q's, so I studied in Q's and I did my residency in Cameroon before moving to the US. I did a residency in clinical pathology, so it's not, and before moving here, I've always been interested in giving back, and it's something that we can always arrange for a specific neat lecture that we can always do. I do teach as an assistant professor at Richmond University too. So, and I would encourage other colleagues if we can create a collaboration where ACPA members can also come in and give some lectures that are needed and also help out. That would be great.
You're welcome anytime.
Thank you.
Yeah. Thank you, sir.
Thank you very much.
Colleagues, yeah.
Please, anyone else, we just have time. You can always log in when you like, and we have 15 more minutes. If you have something to say, it's time for connection usually. And our goal really for the town hall is for us to help Cameroon in any given way. Our time for complaining is over. We should be able to, it's more collaboration with our colleagues back home. Whatever way we can collaborate, learn from them, and also them learn from us.
Question.
Yes, please. You can always unmute
Hi.
yourself.
Oh, can you hear me?
Yes, Larissa.
Okay. Thank you so much again. I was wondering, do we have any dietitian, nutritionists? I'm just mentioning that because, you know, I also cross-train in functional medicine, and we all know that diet has a big impact in the cancer rate and things like that. I don't have any studies for like Cameroon, but I'm just wondering for the folks that are practicing in Cameroon right now, have they seen an increase, or is it just because we're testing more, or do we think there's a diet change impact in our diet, in the cancer rate in Cameroon particularly?
Yeah, I don't know if anyone is going to take that, but Larissa, I think back home, there have been a lot of change in what we eat universally. What we're having in Europe is the same things that are moving over to African countries. We're exporting a lot of poor habits in the way we do culture food, the way we culture animals, the geo growth of things. But I don't know if that kind of study has been done. In Cameroon, we really lack data. So the first thing in Africa and back in Cameroon, in our public health departments, our epidemiology departments, is for us to gather data. I think that's where we have to begin. If we want to ever influence policy, we need data in order to show the government that cancer is really a problem. If we are not even able to do colonoscopies and endoscopies, we're never going to be able to actually know the amount of colon cancers that exist. If we don't have registries in cancer centers that are being used, Dr. Kuya left. I work with her a lot. Dr. Kuya, we have a group where we discuss cancer patients. She's an oncologist at Bingo. She trained in South Africa. There's also Dr. Tunsi, who is there, who is a radiation oncologist. I work with both of them, and I work with those in the regional hospital in Bamenda. The group has been a bit silent for a while, but it's a group They control the people they add. They had asked them to add, I had asked them to add Larissa, to add a few other oncologists there in the past, but it's been a bit lacking. But if we have data, then we'll be able to understand these things. So Larissa, most of the time we don't have data. The second thing in Cameroon, as I told you in the beginning, I have had the privilege to understand the Cameroonian system a little bit more, though because I trained there, we have a tendency to see shortage and just train in one particular area without really having a focus. I'll give you an example. Cameroon now trains so many physicians that those same faculties could have diversed and also trained specialist nurses. We should have been training oncology nurses. We should have been training nurses in cardiovascular diseases. We should have been training nurses who are going to be, we should have been training more nurse practitioners in different fields. That's things we should have been doing. Do we have a school that we train physicists? No. We want to get radiation oncology move forward, but we don't have a school. Cameroon has brilliant physicists that are found in the diaspora. One of the most brilliant guys you can imagine. A lot of them are Cameroonians. You may not believe it. There is one guy who is found in the Biden administration thing. So we have physicists. We should have been training physicists, dosimetrists. Do we train dietitians? I don't know the schools that train dietitians in Cameroon. There may be, and I may lack information on that. Do we even train people, the other auxiliary members that have to work in the healthcare team? Social workers, we have a way of training them. But we have a tendency of looking at, we have a need assessment is not done very well. We just go in, we create 20 medical schools. We know the ones that still have quality, but we just create medical schools and create medical schools. Then doctors become frustrated. You create thousands of doctors. Everyone is moving to the diaspora. You're just creating doctors for the diaspora. So assessment needs to be done, and we need to train according to need. We need to change. Cameroon still. So in QS, where I train, I'm always saying it, QS has subspecialties in internal medicine, but they don't train infectious disease doctors. Can you imagine that Cameroon is an infectious disease team? So I don't know if they assume that every GP is an infectious disease doctor. I don't know yet if that's the assumption. But we don't train infectious disease doctors, and that is why when I was training in QS, nobody does a culture for adult patients. Nobody. I'm going back into that. Nobody does it. The pediatricians do it all the time. They are excellent in doing things like that. I'm not condemning the system, but it's the way we assess need. If truly we believe our problems are infectious disease problems, then we should be training infectious disease doctors. I train as a medicine biologist. Medicine biologists are not infectious disease doctors. We just confuse a lot of things at times, but it's a discussion for another day. So need assessment is super important in Cameroon. And we can use the National Medical Council. We can get influence with the minister. We do have a diasporan committee with the minister. I'm part of that committee, but it's been a bit shaky. You're part of it, Larissa, but I think I still have access to the minister from time to time. We can influence policy if truly those in the diaspora have a group that is strong enough. If you have a group here in the US and you are willing to do good things in Cameroon and you want to meet the minister, let me know. Send me a message. I would arrange for a meeting.
I actually do. I actually talked to 2 groups of nurse practitioners that are very interested. That's why I was asking you, looking at the dietary aspect, not just that, I mean, several things, but it's just like a matter of like finding a pathway and the correct people to connect with to actually impact. You understand what I'm saying? Because I know lots of people are doing different things, but until we understand that we have to do it as a group, we're not going to move forward. I mean, you know that as well as I do. Yeah, I'm just trying to make connection with whoever is in Cameroon right now that are looking at those things. Hey, reach out. I do have a couple of groups that are very active and they're willing to work.
Yeah,
Hi,
so
Dr.
you can put my name on the list.
This is Dr. Samuel Dinjakat with Faith Gardens and Grace Gardens. I was in Cameroon this last summer in July, and I happened to have a student who was doing her internship in nutrition, and I was curious. I asked her, I went to her and asked the name of the school. So she's doing a bachelor degree in nutrition at the University of Bamenda. So I took the number from her, and my plan was that when I get back to Cameroon this November, I will go to University of Bamenda and find out exactly what kind of curriculum they have. So that was my first time of meeting a student, a nutritionist student doing an internship. So they do have it at University of Bamenda.
Good. Thank you, Dr. Samuel, and thanks for all what you do. I know you were recently in Cameroon, and thanks for everything.